It is 5:31. As the quorum of the board is attendance, I'd like to call to order the meeting of the Central Health Board of Managers. The first item of business is citizens communications. Do we have any? Emily's giving me a signal that there is somebody. There's Yvonne. Welcome, Yvonne. How are you?
Doing well, thank you.
Hi everyone, my name is Ivan Davila, Director of Communications and Community Engagement at Central Health. And we have one speaker signed up to speak for Citizens Communication, and she knows the public hearing and citizen communications guidelines for Central Health. So her name is Barbara Scott, Miss Barbara Scott, and she is representing the Colony Park Neighborhood Association.
Welcome, Ms. Scott. Thank you for coming in this cold weather.
Thank you. I actually signed up for number 10 because I thought there would be more people here. But thank you for allowing me to do this. I have copies of what I'm going to read to you. I'm here to address the Colony Park Lakeside community's surprise, displeasure, and concern in hearing of the announcement of the unexpected retirement of Central Health Enterprise Chief Administrative Officer, Mr. Larry Wallace. The Colony Park Lakeside community, along with other communities in the Eastern Crescent, have been left to languish in what we refer to as a healthcare desert that was created by the lack of concern by the very entities that were charged with providing much-needed health care for the less fortunate. Mr. Wallace became our champion and spearheaded several healthcare initiatives in the area, including the initiative of building a brick-and-mortar healthcare campus in Colony Park. Through his hard work, honesty, and dedication, he gave us hope and light at the end of a dark tunnel. How does this retirement affect not only Colony Park, Lakeside Project, but all of the projects under Mr. Wallace's purview? The retirement announcement was not made by Mr. Wallace, which leads us to believe this was not at his request. Our question is, why now? Why the secrecy? And when will the community be informed? On several occasions, Mr. Wallace and I discussed his retirement in relationship to the Colony Park project. I was told probably in 2 years when the project would be nearing its conclusion. The Colony Park Lakeside community is asking the CEO and the Central Health Board if you have exhausted all means to retain Mr. Wallace. We believe this is the only way to ensure the success of the projects that he has so graciously championed. Since the community has not been given any details of what we see to be a forced retirement, it is our belief that this is another example of systematic castigation of another well-qualified black man. We ask you to reconsider your decision to work with Mr. Wallace, and in doing so, continue to work with the community. Sincerely, Barbara D. Scott, President of the Colony Park Neighborhood Association. Thank you for allowing me to do this. I'm very disappointed. I'm very, very disappointed. We thought that we were on a good road and a way to bring health care to an area that has been so disenfranchised, and to hear not from Central Health or not hear from Mr. Wallace. I happen to have seen it on an email that was sent to someone else. I'm disgusted. I'm disappointed at the way that this was done, and I think that the community is being slighted in a way that it should never be slighted ever again. Thank you. I have copies of this.
Thank you, Ms. Scott.
Thank you.
Any other citizens? Yvonne?
No.
No.
Citizens Communication.
All right. I'd like to note for the record that agenda item 8 will not be discussed this evening, though this item is 8, discuss and take appropriate action to authorize Central Health President and CEO to execute all documents necessary for Central Health to obtain a capital line of credit from J.P. Morgan Chase, and B, adopt a board resolution authorizing these finances, expenditures, and reimbursements of Central Health funds from finance proceeds. All right. Next is the consent agenda. C1, approve the minutes of the September 18, 2019, and September 25th, 2019 meetings of the Central Health Board of Managers. C2, receive and ratify Central Health investments for September 2019. C3, receive and discuss and take appropriate action on a presentation from Southwest Retirement Consultants and Branch Banking and Trust, BB&T, on the quarterly investment results of Travis County Healthcare District Retirement Plan and the 457 Deferred Compensation Plan, including recommended fund changes as recommended by the Budget and Finance Committee. C4, adopt the fiscal year 2020 Central Health Investment Policy as presented by the Travis County Cash Investment Management Department and amendments to the Central Health Reserve Policy as presented by Central Health staff. Members, I have been informed by Central Health staff that the amendments to the Central Health Reserve Policy are not yet ready for adoption this evening. Unless there are questions about the investment policy, I would recommend that we proceed to approve item C4 without discussion, and that our motion to adopt the consent agenda exclude approval of the amendments to the reserve policy. Do I hear a motion? Manager Bell.
I move that the board approve the consent agenda items C1 through C3 and the portion of item C4 that relates to Central Health Investment Policy.
Okay.
Okay. I have a motion on the floor by Manager Bell, seconded by Manager Jones. Any discussion? Seeing none, all in favor?
Aye.
All against? Any abstentions? Let the record show that the motion passes. Regular agenda. Agenda item 1, receive and discuss a presentation from Kristen Doyle, General Counsel and Deputy Executive Director, Cancer Prevention and Research Institute of Texas, CPRIT. Manager Jones.
Yeah, I'd like to move that we restrict our regular agenda items, with the exception of those that we feel as a group, to a discussion of 10 minutes at max.
Any discussion? Seeing none, all in favor?
Aye.
Motion passes. Kristen, how are you? Welcome. Thank you for coming.
Good evening. Thank you for having me. I'm Kristen Doyle, and I'm with CPRIT. As you may know, CPRIT was created in 2007 by a vote of Texans to amend our Constitution to authorize up to $3 billion in general obligation bonds. And I've included our mission. It was given to us by the Texas voters, but I can summarize it in 3 words. It's investment, infrastructure, and innovation. We opened our doors in September of 2009 and made our first grant in November of that year. So we've been making grants almost 10 years. In that time, we have awarded $2.4 billion in 1,500 grants to 108 organizations, companies, and institutions in 27 cities throughout Texas. We've become the 2nd largest funder of cancer research behind the federal government. And that's our first part of our mission, is to invest in the research prowess of the Texas institutions. 70% of our portfolio goes to universities throughout Texas, including UT Austin. And certainly you can understand now with the Dell Medical Center, we are great partners with Dell Medical Center, but even before Dell started, we have been making awards to UT Austin because, they have very interesting ways at coming at the cancer problem. Engineers, physicists, chemists were receiving awards because they're coming up with innovative ideas on how to address cancer issues. We've made 59 research awards to UT Austin, and including one of our signature programs, our Recruitment Awards. With the Recruitment Awards, institutions can bring somebody from out of the state to their institution. So these are preeminent experts in cancer research, clinicians, in all stages of their career. We have an award for first-time tenure-track investigators, rising stars, and established investigators. And in fact, one of our established investigators that we brought to the state in 2012 is Dr. Jim Allison, who received the Nobel Prize in Medicine last year. And these researchers come to Texas, bring their expertise, work with the talent that's here. I've included 3 of the recruitments that have been brought to UT, including Dr. Eckhart, who is the founding director of the Dell Medical Center Livestrong Cancer Center.
And my classmate. She and I went to med school together.
Really? That's good. Continuing on the theme of what we're doing with UT Austin, I've included 3 other outstanding researchers. Dr. Yankee Love, again, is another CPRIT scholar, one that was recruited here from Vanderbilt. He's doing something interesting with computational oncology. So he is working, he's doing a clinical study with Austin Radiological Association, Texas Oncology, and Seton, where he's looking at breast cancer that has received treatment pre-surgery and analyzing all of the data in terms of determining the models on where you can predict who will not perform the best with the medicine prior to surgery and not need additional surgery. And so with that finding, he is hoping to expand his clinical trials into other solid tumor cancers. Another one is Dr. Eberling, and I don't know if you've read about her in the press. She has done a lot of exciting things. She got the Genius Award last year for the mass spec pen, which is another thing that CPRIT has founded. We've helped found the research and the development of that. So that's, literally you're holding a pen, a surgeon's holding a pen during a surgery while they're taking out a suspected tumor. You can touch the mass spec pen to the tissue and determine in seconds whether it is cancerous or not cancerous. So you're not having to, come back for additional surgery because you didn't get clean margins. So it's really phenomenal. It's being tested in patients already. And just this week, she published a paper on thyroid cancer. They've moved now into thyroid cancer. When you do the small needle aspirations, a lot of times they're inconclusive on whether or not you have thyroid cancer, and so people are having their thyroids removed anyway, which means a lifetime of drugs. Mm-hmm. And with the mass spec pen technology, they are able to tell in this very small clinical trial with 90% accuracy in terms of thyroid cancer. So obviously that will continue to go through its paces, but those are the type of things that we are funding. Also included Dr. Pignone up on, and he has been doing tremendous work at UT Austin in prevention. And I'll talk about that also. That is one of our missions. So I know that we are working with Central Health in the screenings that Dr. Pignone is providing. The second part of our mission is growing the life science infrastructure in Texas. So that's the ecosystem. We have all of this great research and a discovery pipeline that's coming out of our institutions. We need to pull that out and get that into companies so that those drugs are making it to market. So far, we have funded 36 companies, all in Texas. 13 companies we have recruited to Texas. We call them relocation awards, but we don't really pay for them to relocate to Texas. We say, if you relocate to Texas, you can have this award. So we're priming the pump in terms of bringing those companies here. And with CPRIT investment, we have increased the life science venture capital by 11% in Texas. In Austin, we have 8 of these companies, of the CPRIT-funded companies. So, Austin is second to Houston in terms of the number of companies that are being founded. This is an important slide because this is where we invest. When we're talking about investing in companies, we're looking at the riskiest part of a company's life cycle. That early preclinical phase and phase 1, phase 2 clinical trials. This is when, the venture companies, the pharmaceutical companies, they're sitting on the sidelines because they're waiting for that data to be developed. It's, as you know, it's incredibly expensive to develop a drug, take a drug all the way to market. It ranges $1 to $2 billion. And it takes 10 to 15 years, so you have to have very patient money. So it's hard for venture and pharmaceutical company to start so early. But if you are not getting the data to move you through the clinical phases, then you are never going to be getting the additional funding. So that's the part that we're bridging. It's called the Valley of Death. It's where good ideas go to die for lack of funding. So we are dropping the bucket in terms of all of the money that has to go into a drug to be developed, but we are a very important part of that funding because we're helping them get the data that's being developed that allows them to bring in additional funding. And because of that, we get asked often, well, where's your drugs, Secret? Where are the drugs that Texas taxpayers have been funding? Keep in mind, we are funding early on, so those are still making their way through phase 2 and phase 3 clinical trials. But one early indicator of progress is the additional funding that's been invested in those companies after we've made our awards. So for those 36 companies, we've committed $430 million. And when I say committed, we do this all through contracts. But our contracts have goals and objectives with budgets tied to those goals and objectives. So we distribute the funding by tranches. They have to have completed goals and objectives in order to get the next round of funding. So we've committed in total 430. We haven't dispersed 430 million yet. But those companies, those 36 companies have been able to raise $3.1 billion in additional funding after CPRIT made their investment. So that's more than a 7-to-1 ratio. And it's critically important. Like I said, if we're the last money in, then we've all failed. We need these companies to be getting the hundreds of millions of dollars of venture capital that's going in, that's carrying them through the more expensive phase 2 and phase 3 clinical trials. Another early indicator of progress is that 13 of our 36 companies have become publicly traded after CPRIT's made an investment. Now, the third part of our mission is accelerating innovation. So we accelerate innovation in research through our cancer clinical trials. And to date, we've funded 132 clinical studies, enrolling nearly 20,000 patients. But where we accelerate innovation, and is my favorite thing to talk about, is in our prevention program. We are able to spend up to 10% of our funds on prevention activities. And with that, we have been able to fund prevention services in every single county in Texas. When you think about the research and the company funding that we're doing, it's pretty much along the I-35 corridor with also Houston added in there. But with our prevention, we are able to touch every single county, and we are going places where, there's not screening. Half of the 5.7 million services that we have provided, half of those services have been in screenings and genetic testing. And many of the people that we are testing, most of them have never been screened before. As a result, the CPRIT projects that we have funded have detected 21,000 cancer precursors and cancers. And we know how important that is. For every dollar that you're spending on screening, you're saving about $26 in treatments. We are finding cancers early, and when they're more survivable and they are less of a burden to treat. Travis County, again, has been an excellent partner with us in the prevention projects. I've listed the projects that are currently active in Travis County. So these are projects that are available to people living here. And Dr. Pignone at UT Austin has 2 right now going, and one of them I know, colorectal screenings. I think we are working with Central Health and providing those screenings. So, CPRIT is the story, of course, in hope and aspirations in cancer cures and cancer prevention, but we are also benefiting the Texas economy. We had an independent economic analysis done in 2018 on CPRIT's activities. So in 2018, our activities for that year are responsible for 10,000 jobs and $1.4 billion in economic expenditures. We were fortunate to have the strong support of the legislature, and we have enjoyed that throughout the life of our agency. This last legislative session, we had a unanimous vote in the Senate, so bipartisan support in the Senate, and near unanimous support in the House of Representatives for House Joint Resolution 12, which is setting up a constitutional amendment vote this Tuesday on Proposition 6, which would authorize an additional $3 billion for Texas to continue to grow on the investment that it has made in cancer research and prevention. Of course, we have talked internally and with our stakeholders on what Texas can do to continue to build on the success that we are already seeing. So these are some of the ideas. One thing that I do want to point out, I haven't talked about, back in 2014, our chief scientific officer at the time, Dr. Margaret Kripke, identified as one of our program priorities childhood cancer. And so as a result, we have always had a targeted individual investigator award for childhood cancer. We have made 150 grants for childhood cancer. So that's both prevention, that's HPV, vaccinations, and research. And with that, comparatively, we are funding 3 times the amount that the federal government is funding for childhood cancer research. The recruitment program that I talked about, we've brought world leaders to Texas through that recruitment program that are making amazing strides in childhood cancer research, and we can really grow on that and make Texas the leader. Another thing is that we want to expand clinical trial access. Right now, if you don't live in Dallas or Houston, you do not have the same access to clinical trials. Even if you're living in those cities, less than 5% of the people who are eligible to participate in clinical trials participate. That slows down drug development, and it's a real barrier to these innovative treatments that are being tested. So we want to look at what we can do to help that. I could talk on and on about CPRIT, but my boss has reminded me that the Houston Astros play tonight. I don't know if there are any Houston Astros. I was like, it's Austin. I don't know if there's going to be Houston Astros fans, but I'll keep it short, so hopefully you can see some of the game. I've included our contact information. I'm happy to answer any questions, but again, I want to thank all of you for your support and your work with CPRIT. This is really an amazing thing that Texas has done. No other state has done this. No other state has tackled cancer the way that Texas has, and we should all be very proud.
Thank you. Managers, questions? Manager Jones?
As an Astro fan, just quickly, are any of the resources for research done with minority institutions in Texas? Does it find its way either through the major universities into these other minority institutions?
Yes, I think we have, I can't remember the number, but we have funding at, I think it's 31 academic institutions. We include training programs. So I can get you a full list of everyone that we are funding. But yes, we are definitely, we're in the Valley. We are, all across Houston and other areas. So it's and Texas Southern, I know, has received at least one award from Texas, and which is very exciting.
Thank you. Keep up the good work.
Thank you.
Vice Chair?
Thank you.
Dr. Bell?
Excellent.
As I told Ms. Doyle earlier, our TMA is definitely behind the bill or the vote, so we'll continue to support you. Thank you. Thanks. So this is an informational item only. No action is necessary. Agenda item 2, receive and discuss a briefing regarding Birch et al. And Travis County Healthcare District doing business as Central Health and Mike Giesland, cause number D1 GN 17005-824 in the 345th District Court of Travis County. And agenda item 3, discuss and take appropriate action on the interlocal agreement between Central Health, the University of Texas at Austin, and Emergency Services District 11 for the establishment of a healthcare clinic in southeast Travis County. I announce that the board is convening in closed session to discuss agenda items 2 and 3 under section 551.071 of the Texas Government Code, consultation with attorney. In addition to our Travis County Council and outside counsel, Ms. Reeves, the following Central Health staff may remain for closed session. For agenda item 2, Mr. Giesland, Ms. Crowley, Mr. Knodel, Ms. McDonald, and Mr. Morgan. For agenda item 3, Mr. Giesland, Mr. Burton, and Ms. Cavazos. You ready to go? All right, so we discussed agenda item 2 and agenda item 3 in closed session. Agenda item 2 is just an informational item, no action will be necessary. Agenda item 3, you want to have the dean and Dr. Morgan come up?
Yes.
Privileges are, yeah, ask questions.
Dr. Morgan, dean, you all come up? Thank y'all for coming. Good. Madam Jones?
Thanks very much for joining us here this evening. I have just a couple of questions with regards to the location of the facility. From the school's perspective, are you wedded to this specific location in terms of your ability to access the populations that needs to be seen in the Del Valley area? Is this the only area you feel, or do you feel this is the best area that can provide those services? Or are you flexible enough to believe that you could continue maybe to work in some arrangement until such area that Central Health may decide to build a larger facility in that area that could benefit the entire community, or work out another arrangement in another facility that would provide the needs you know? Because as you know, Southeast Travis County is a huge area.
Yes.
And accessing those populations, even in this location, from a transportation system we hear is problematic still. So I guess my question to you is more of a, are you flexible enough or that if we were able to develop another strategy, that you would be accommodating of that?
So let me say first and foremost that it's 2 years this month that we started this conversation. It's 2 years. And so I know that the Kellum Road location is a very good location in regards prior to even us finding and getting opportunity for that location. It had been looked at for other organizations, and at the time couldn't find a spot on that in that area. As far as being able to provide services quickly to folks out in that area, I would moving forward in our arrangement that we have to try to continue to work with Travis County Fire Rescue on that land that's provided. For us to provide services in that space, I think is still the best way to go, in my opinion. We have approached the Del Valley High School about trying to expand services. That has not been approved. That is not, it's been discussed with them. So I don't see anything in the near future that would allow us to provide care and services to expand to the adults, specifically the MAP folks, anytime quickly. And I do think that this is a great location. It's centrally located to the population, and transportation will be an issue for a while.
And probably no matter where you are, it's,
Right,
I
right.
think, an issue for some part of the population.
So if this facility is going to be built, it's not going to be built overnight. So
No.
we're still going to look at a period of, I don't know how long it'll do. Is there a time frame
Probably
for the construction of it?
a year, a little less.
From the time that the permit is back, and according to the Volker Construction folks, we have the design, and we have the design done, and the time the permitting is back and the time you break ground, they're projected 12 months. So there's things that have to come before that.
Right.
So,
Okay, all right then. So you feel that, for your conversation, you feel this is the best location, given what we currently have in the time frame in which you want to do it?
I do. Yes, sir.
Okay.
Madam Brown?
I'm really excited about you guys going out to that area and providing services. I guess my question is, are you representing, as University of Texas, comfortable with the arrangement that is being developed here, and feel that it will have the necessary support by all parties to be a success?
Can I take it?
Absolutely.
Yes, the short version. You know, again, as Dr. Morgan said, we've been on this journey for 2 years now, but we've actually been in the Del Valley community for over 20 years. And we, when other people left, we stayed. We feel very committed to that community. We're trusted by people. We are treating the grandchildren of some of our initial, patients. We have employees that live in the community, that we're involved in a major assessment right now of social determinants of health, learning even more about the community. We'll have a community advisory board. So it's never an easy job providing care, as you know, to the underserved. But we really are excited about this somewhat, innovative partnership that has been challenging. I think everyone that's involved in this three-way partnership has absolutely the goal and the mission front and center to do something good for that community. It's hard because we all represent, we're three different government agencies that all have different boards, all have different lawyers.
Sure.
But I think what Dr. Morgan and Mike and Chief Bailey and Chief Pack have kept front and center the whole time is that we all have the same goal. And they've kept talking, and they've kept working on this through many weekends and nights, and really come up with a solution that I think we definitely feel comfortable with. And I'm sorry.
No, I agree. I agree, yes.
Thank you so much. Appreciate it.
And I also agree. It's about the patients. And with that, Dr. Bell?
I would like to move that the board confirm its previous actions authorizing the president and CEO to execute a contract with the University of Texas at Austin and Travis County Emergency Services District 11 to establish a clinic in southeastern Travis County under the terms set out by the board in our previous actions. And I further move that the authority granted in this motion and the effect of any signature transmitted by the president and CEO consistent with this motion expires at 6 p.m. on November 15th, 2019, will be fully and irrevocably rescinded and nullified if the contract is not fully executed by all parties as of that date and time.
Here, a second. So I have a motion by Manager Bell, seconded by Manager Oliver. Any discussion? Seeing none, all in favor? Aye.
Aye.
Any abstentions? Yes. And so we have 2 abstentions and 3 in favor, so that motion passes. Thank you, doctors.
Thank you.
Thank you all.
Bye.
Agenda item 4, discuss and take appropriate action on the appointment of one member to the Integral Care Board of Trustees. Manager Bell.
Members, before I make my motion, I would like to sort of outline the process that was gone through to bring to you a nomination for this particular appointment. You may have received an email back in August that was sent to the managers to nominate a candidate for the Integral Care Board. The email included the criteria that were needed by the board as specified by the board chair. They were healthcare finance experience, substance abuse disorder expertise, direct experience with substance abuse disorder and or mental health via a family member or direct care experience. The nominations, of course, from the board members would be sent to the Integral Board Chair if we had received any. The only information we received was from one board manager who outlined an interested candidate, but after we contacted that interested candidate, we never received any of the required information to look at the biographical information and her experience with regard to mental health and substance abuse disorder. During this time, of course, we or the staff, had extensive conversations with the Integral Care staff and with the Central Health Board Chair about the vacant position. In September of 2019, based on discussions with external affairs staff, Integral Care staff, and subject matter experts, 2 candidates were identified, and each of those candidates provided information. The information regarding, in October of 2019, which is the beginning of this month, information regarding the 2 candidates was sent to the Central Health Executive Committee members, and we requested that the staff discuss the candidates with Integral Care and ask the Integral Care's board chair for input to see if either candidate would be a good fit for their board. The Integral Care board chair returned information requesting Trish Young Brown be approached to serve on the board, and she had stated to him that she was interested in serving. Dr. Zamora communicated with Trish, and Trish has agreed to serve if nominated or if appointed. The Integral Care board chair feels that Trish Young Brown brings experience which is now missing from the board with the departure of Tom Young. That experience is healthcare finance experience, substance use disorder experience, and experience with substance abuse disorder and/or mental health, including a family member or an individual with direct care experience. Trish has more than 20 years of experience leading multiple healthcare and community-based organizations, most recently, of course, as the president and CEO of Central Health, the Travis County Healthcare District created by voters in Travis County in 2004. She's a certified public accountant, and she holds a BS in accounting from the University of Denver. Currently, Trish is the chief executive officer of the Thinkery, a play-based learning experience for children and their families here in Austin. She also has direct experience with substance use disorder and with family members dealing with mental health challenges. So, with that information to my fellow board members, I would like to make a motion to appoint Trish Young Brown to serve on the Integral Care Board of Trustees.
Here, second.
Second.
We have a motion by Manager Bells, seconded by Manager Greenberg. Any discussion? Manager
I
Jones.
just have one question. You indicated there were 2 individuals that were identified. I'm assuming that the executive committee reviewed, consulted, and felt that this was the top of the 2, or was there any consultation or consideration of the second?
We did say that we would take the recommendation of the board chair of Integral Care if these individuals met what they needed on their board. The board chair of the Integral Care Board came back with a request of asking Trish Young Brown.
Can we ask who the other person was?
Yeah, we do have information, the names, I don't have them in front of me, but I can surely give them to you.
So do we have to decide today without knowing who the other candidates were? Because we are the ones who get to decide this, not the board chair of Integral Care.
Well, but
I mean, I get that he can make a recommendation.
that's
but-
correct.
But it would be nice for us to know
Well,
who all was,
I'm assuming from your comments is that the second person in his choice was not the better of the 2. And
I'm
for us to
assuming-
make the recommendation without knowing what the other one is the question of where I'm trying to go at.
I have not talked to the board chair of Integral Care, so I do not know if he took into consideration the 2 members that we sent, or if he heard from Trish or knew Trish was available and decided that she was the best fit.
Okay.
I
so
did not
was she
ask.
one of the 2?
No,
Oh,
no.
so you, okay.
As we do in most boards, we do ask the chairs what they need. and Hal came to me and said, to replace Tom Young, we need someone who has the finance information or knowledge and also healthcare policy knowledge.
The two candidates had that.
The two candidates had the experience, that's correct.
Okay. Well, can we not just bring to the full board who the two candidates are? Or is that
Well, sure, I mean,
problematic?
I can surely provide you that information, and I don't have it in front of me right now.
I don't either.
And so, if you choose to, vote against the motion and we bring it up at a, or make a motion to postpone this,
We make
I
a
am
motion
fine
to
with that.
postpone. Yeah.
and
So we can I think we should be able to review too.
Well, I think that the recommendations come forth would be a good recommendation. I think she would serve well and do quite well. It's just that I don't have a measure to measure her against to determine if that's the better fit. That's all I'm saying. By no means, I mean, I have no question that she could serve admirably, but I don't know who the other person is. So I think that's the nature of our concern about.
And just so I can say that we did look at I did, when they sent it to me, I looked at it. Did I memorize it? No. All right. But they looked like good individuals. Trish was not a part of the picture at that time. So she was not included in the two.
I thought she was one of the two initially, and then, so I think I would just like to know who the other two are and maybe look
Be
at the
happy to
resumes as well.
Have that
So if we
information
could postpone this,
provided
this
to
would be great.
I withdraw my motion.
Madam Speaker.
Yes. Council, I need to ask a procedural question about the policy itself, or the process itself. And is this something that I can tee up with the board on this discussion, or is it just particular to integral care? Or is that a discussion I can tee up?
I think you can tee that up.
Okay. So, members, I think postponing gives us an opportunity, because there's a policy issue here that needs to be discussed. And when we put out calls looking for candidates and trying to recruit as diverse a pool as possible, people have to make significant time commitments, and they have to have the expertise to be able to bring this to the table. And I think the recruiting efforts, I don't know if you all made calls to individuals and said, hey, would you be willing to serve in this capacity or not, and how those calls went. But I think we need to look at what happens when there is a recruiting effort, and then you have a board chair that says, this is the individual that I would like to see, because there's certain differences. Obviously, if that board chair or board as a whole, could be any board that you all appoint to, find a candidate and feel like, wow, this would be the ideal fit for us. We didn't discuss that in the executive committee whenever we were talking about these policies. And so I would like to bring that back, just to get a sense about where you all would like to go with this, because this is a rather unique situation. And so I'm more or less asking just, for a placeholder, that when we do come back to this, that we have that policy discussion, because this situation is likely to repeat itself.
I think what the managers would like to hear is those other candidates, Mike. Do we have
Yes,
that
sir.
information?
Yeah, we'll have to bring that back,
Yeah.
because we talk about in the posting, it says the one, so we'll need to bring it back to talk about.
But to the point that Mr. Giesman was referring to, is that I agree that there should be other considerations other than the board chair of whatever organization we're appointing to would be the sole decider in that, because we may have a different mindset or modus operandi for what we'd like that agency to go to. That
Agree.
would be advocated more by another board, another representative than the other. So it's, therein lies is the nature of the discussion I raised, is that we have no problems with him or her, whomever the chair may be, and make a recommendation, but as of our fiduciary and our policy responsibility is to make sure that it's the right fit. So I think that's why, what we're asking for here.
Well, I understand that, Shannon, but who best would have the decision of who would be the right fit, except for the chair of that board?
Well, I can bring up when I was appointed to the board, the chair certainly didn't think that I was an appropriate appointment. And she wrote a letter to that effect. So I mean, and I hope that y'all can see value in my service to this board.
We
Of
do.
course, we do.
But, you know,
We do.
2 years ago, that was not the case. So,
But I would sort of differ with you in your philosophy there. I grant what you're saying, but I don't always agree that the chair, I certainly have the chair has purview more than other folks. But I'm saying that collectively, the board has the expertise and the knowledge, and I view the gravitas that the chair would have. And so that's why I say as a collective decision by a board would be very valuable in terms of those recommendations. That's all I'm saying to that. I don't undermine the role of any chair, but I think that the expertise that all board members have, and that's why the opportunity to vet, to discuss, to interact from a collective group, we can get a recommendation that will be reflective and we can defend. So that's my position on that.
You've been heard. So we withdraw the motion then?
I withdraw the motion, and we will postpone this item until our next board meeting.
Thank you, Dr. Bell.
And I would ask staff if they would assist me in getting the information so that the board members can have the information of the other 2 candidates.
So there will not be any action on agenda item 4. Agenda item 5, discuss and take appropriate action to reappoint Eddie Sutherland to the Board of Directors of Sendero Health Plans, Inc. Manager Bell.
Mr. Chair, you have a memo in your packet with regard to Mr. Southard. Mr. Southard has been a board member for 2 terms now. He has been an excellent attender, contributor. He brings with him a background of insurance, so he does understand the need for insurance and how insurance operates. And he is willing to be reappointed. I, as chair, would recommend that he be reappointed. We did not go out to find any other individuals to appoint since he agreed to be reappointed. And so with that, I would like to move that we appoint Mr. Eddie Southard to serve on the Board of Directors of the Sendero Health Plans Incorporated.
Do I hear a second? So we have a motion on the floor by Manager Bell, seconded by Manager Oliver. Any discussion?
Just have a quick question. Is there any kind of limitation typically on the number of terms that somebody serves on the Sendero board, or?
The bylaws outline that the board members serve 2-year terms, and it does not set a limit.
Limit, okay.
Okay? And so it's usually when the individual decides that they have had enough, that they decide to resign or not be reappointed.
Asked not to be reappointed.
Or ask not to be
This
reappointed.
individual has served 2 years so far?
2 terms.
2 terms, so this individual's already served 4 years?
Yes.
Okay, and this would be an additional 2?
Yes.
Okay, just curious, I didn't recall from the bylaws if there was any. Okay.
I looked at that in the bylaws, thought about maybe putting a limit in there, but it's funny, at the time that we were doing the bylaws, we weren't very hopeful about the organization in general, so I was thinking of other things besides term limits.
How long have people typically served on the board of Sendero?
I know Lynn, I was on the board from 2013 until 2015, and Lynn was the actual board chair president,
Right,
and she's still on the board.
so at least 6 years
6
or more.
years, for sure.
Or probably more like 8, okay.
I mean, I don't know
Yeah.
if she was on before I got,
Yeah,
She
I was just
was-
curious. I
she
didn't
was
know
the
how-
chair when I got on, and
Right.
so she may have been the chair for a couple of years before, so.
I came to Central Health in 2013, and she was already on Sendero.
So she's been on for a long time.
Manager Jones?
Just a couple of quick questions. One is that I don't know Mr. Souther, so I concur with your recommendation based upon what the information provided. We did have a discussion at the executive committee meeting. I don't know if it was on this topic or if it was on another, a bylaws discussion regarding asking representatives from boards that we appoint to come forth and sort of give us updates. I know we agreed that that would not occur, but I guess my question, in light of what we've gone through with Sendero over the last year and a half since I've been here, did Mr. Southard come before us? I don't know him, so I can't speak, and speak on behalf or support, or do you have any reference in terms of,
Well, first of all, we asked Mr. Southard if he would come tonight, but he had another commitment that he was unable to make it. The board members, but you weren't on the board at the time, met Mr. Southard. We had a gathering at Community Care at the Southeast Health and Wellness Center where we invited all the boards of all of the enterprise entities to a gathering. I think it was light food.
Presentations from
And we had
different entities.
presentations from all of the entities there.
this is prior to my coming on board.
This is
Yeah.
prior to you coming onto the board, and that was when he was actually introduced to the board members. But he has not been to a board meeting since he has been a member.
Well, I'll support him based upon your comments, but I guess one of the concerns, it goes back to my concerns about our appointment of members, is that certainly when an agency is under distress as Sendero has been over the last, at least since I've been here, would seem prudent that board members would have come here on, given their affiliation with us and given our support of them, to make an argument on behalf of the agencies for which they're in. So that just raises a question. I will intend to support him, but I think that built into the expectations of appointments is that we instill in board members, that's expectation. When I was asked to join this board, I was asked, would I be willing not only to volunteer my time, but make the commitment to do all that's necessary. And to me, that's important. So I just raise that as a question of discussion. No question about him. I don't know him. I can't speak to him. And I will support him, but I'm just saying in future board meeting recommendations, I think those are things that go back to what Mr. Geisler said. We need to look at what we want in our recommendation for board members.
Yes, and I met him at that meeting. I don't know him, but I'm willing to support you in this. But again, given the situation that we've seen since Sendero, since its inception, I do think it would be good to get that kind of update from board members. And I also think, Mr. Geisel, this brings up getting back to the policy. When we're making these kinds of appointments, should the board or members of the board who are available be offered the opportunity to meet these people in person as other entities do when they are making appointments. And in fact, some of those other entities interview you with a public tape running.
Manager Bell?
I agree with Manager Jones. I think that your point was well taken. I think we thought as a board, Sendero board, that we were going to become intertwined with this board to deal with an open meetings issue. We found legally that we could deal with it in another way, and thus our board did not have to join this board. So that was one sort of outcome that we were looking at, of being able to become closer and have more intimate discussions with regard to Sendero and the issues going on with Sendero at the time. But I do agree with you. I think there should be another venue in which we can meet the board members. And then speaking to Manager Greenberg's issue, when I was initially appointed, and Mike, was initially appointed to the Sendero Board, we were interviewed.
Right,
We were brought here in
exactly.
the training room, and the board members, I can't remember who they were at the time, but they asked us questions and, wanted to know what our interests and our
Right. Mhm.
thoughts were with regard to Sendero, et cetera. So that could be something that we could
Exactly.
consider
Right.
when appointing board members to have I don't know whether it would be part of a committee meeting or a special call meeting, or if it would only be 3 board members or whatever.
Yeah.
I'm not sure how that would work.
Not
but,
either, but that
that could be a process that would accommodate both Manager Jones and Manager Greenberg's comments.
And I respectfully disagree with everyone, because you're asking a volunteer to come, give up their time for that board, and then you're also asking them to come in and be interviewed.
So just a reminder that we have a motion that was voted on for a 10-minute discussion. You've
Okay.
exceeded that time.
I move that we
All right.
call the question.
All right, so everybody, are we okay with this
Mhm.
motion? All right, so everybody in favor say aye.
Aye.
All against? Any abstentions? Motion carries. All right, agenda item 6, receive and discuss a report of the preliminary September 2019 financial statements for the Community Care Collaborative. Mr. Knodel and Mr. Morgan. Please come up. Or Lisa. And Lisa.
Or just me.
Or just you.
Okay, thank you, Lisa Owens. So we are here for financial statements. This is our preliminary draft financial statements. As you know, we are starting our audit in the near future. So while we don't anticipate any significant changes, the financial statements are preliminary until the audit is complete. But we would like to present to you the Community Care Collaborative year-to-date. So, quick highlights. Cash is consistent year over year. We did have a member payment of $11 million from Central Health in September. Total liabilities were at $20 million, and net assets at $14.8 million. So just to quickly go through the balance sheet, you'll see total assets primarily made up of cash and cash equivalents of $34.5 million. Accounts payable and accrued liabilities at $17 million. One thing I would just point out is that includes incurred but not reported, which is a process we go through with our providers. Claims are due 95 days after they're submitted, so we have an estimating process that will continue. And that number is less this year, driven by a couple things. We have great data now. We are in the first full year with our new TPA. We have a great team that is working very closely to make good estimates. But also, a big part of that is that the DSRIP program has changed, and so there is not a big liability for our DSRIP program. Those outcomes are earned and reported monthly. So that just is a highlight of the variance there. Deferred revenue is an estimate we make for any potential DSRIP that may be audited and at risk. It's an estimate. And then again, total liabilities is the total there at $19.6 million. That leaves our net assets at $14.8 million, and again, $34.5 million in liabilities and net assets. Total revenue for the year, $137.5 million, or just under $0.5 million. We did have DSRIP revenue of $75 million, member payments totaling $56 million, and interest income, which is the $622,000. And then our programs, we have healthcare delivery, UT services agreement, and DSRIP. I'll talk a little bit about DSRIP. As I mentioned, that program this year, we are paying for outcomes. It's not paying for programmatic milestones anymore in the new second 5-year round of DSRIP. So we do estimate our project costs to be for the year about $9.7 million. Our total healthcare delivery is $127.6 million, and that does leave the net assets at 14.8. We do have about a $5 million emergency reserve, excuse me. Looking at healthcare delivery, we are at about 87% of the total budget at just under $83 million of expenses. We have more details on primary care and specialty care. We have just about 103% in specialty behavioral health. You'll recall that the board approved an additional $420,000 partnership with Integral Care for school-based counseling, and that is included in there. Post-acute care, we made adjustments to that budget throughout the year, and just at 95% of those adjusted amended budget numbers. Pharmacy at 92%, and then medical management and the remainder of our budget for the departments that operate in the CCC for healthcare delivery, and again, we have more details for that, again totaling just under $83 million. Primary care, $48.2 million year to date for the year. We talked many times throughout this year about the changes with El Buen Samaritano and Lone Star Circle of Care. And we've talked as well about changes to how we contract with many of our providers, such as moving specialty care from the primary care line to the specialty care line for community care, and building in more performance-based incentives at the end of these contracts. So again, primary care at $48.2 million. Looking at specialty care, we've no significant changes as we entered the year end. I would say, again, we have great work going on between our teams in the finance department and the healthcare delivery department, as well as getting good data from our TPA. And so we are estimating to end the year at just under $7 million in specialty care. As we've talked about throughout the year, the consultation services, that project will be executed in FY 2020. So that was anticipated to be under budget. And as well, some of our specialties are over budget or under budget, where, for example, with community care, we're serving patients in 2 or 3 different specialties. They may be over or under budget in one, but the contract is not over or under budget, and that, again, is just using estimates to budget and then the actual services that were required through those specialties. Looking at our healthcare delivery operations, these are the departments that were functioning in the CCC in FY 19. Service delivery operations, claims payment analysis, etc. The total amended budget that we had for that was just under $11.5 million, and the expenses are estimated to be at $8.4 million for the year. So just at 73% of the budget. With that, I'm happy to answer any questions.
Anders? Andrew Gilbert?
Is this our year end?
Yes,
September?
September
Okay.
30th is our year end.
So, will you remind me, I know you just explained it, who gets the district project costs? Who's receiving
We
them?
have 3 contracts for that right now. The community care, Lone Star, and Hospice Austin.
Okay.
And that is an outcome-based program now, so the MAP population is the population that the outcomes are
So
measured.
that's the lift in the district project cost year over year?
I'm sorry, that's the what?
The lift in the district project cost year over year?
Yes, if you'll recall, last year was the first year of the new outcome-based measure, and that program had a delayed start.
So,
It shifted to a
Yeah.
calendar
Calendar year.
base.
that's, okay, that's fine, but, so with with respect to our regular healthcare delivery, I mean, we're like $6 million under budget. When I look at that, it to me seems like that's $6 million of services that were not provided.
So I don't think that's the
But I mean,
case.
and that's a very simplistic view of it,
No,
but yes.
understood.
So I'm going to allow you
Unfortunately,
to explain.
the financials aren't really a good indicator of what's happening on the ground in terms of services. I think in December, actually, we're having a conversation in strategic planning committee around what kind of dashboards the board wants to see related to services and how it
Yeah.
ties out to financials. And I think you'll,
Exactly.
I think you'll
Outcome
be
measures.
pleased with the service levels. In almost every area, we are exceeding all prior year utilization. And it's certainly more nuanced than that. You know, a lot of these contracts are available, these services are available on an as-needed basis. You know, this year in particular, one of the areas that we've had lower utilization is through our agreement with Austin Cancer Centers for radiation oncology, and that's not because of a lack of funding. It's just that we haven't had as many referrals for that service this year. But from a primary care standpoint, specialty overall, urgent care and post-acute care, I think we're serving more people, providing more services than we ever have.
Good. I just didn't want anybody to look at that and say,
Understood.
no, we're not providing services, so.
Mr. Greenberg?
So that ties in my question. So as far as the total number of people,
Yes, ma'am.
do you have how many we have served this year as opposed to last year?
We don't yet. A lot of those measures lag a little bit because
Right,
of the billing
because it's
cycle.
in the year, okay.
Generally, in the second quarter of the year, we'll
So,
have close
in
to
January.
finalized numbers for the prior fiscal year.
Okay, okay. And then when you look at some of these areas such as palliative care, and you see that hardly any of the budget was used, is that because the program is delayed in implementation? Can you explain that?
So each of these is a little bit unique.
A budget is a
Palliative-
plan, I
Yes, ma'am.
understand.
Palliative care is a good example where the provider, that was a new initiative over the course of the year. Actually, I think we entered into that agreement towards the close of FY18. That provider has had limited capacity to see new patients, and as a result, we're looking at other potential service providers to add to our network.
So would we keep the contract with them, or?
I think we'll keep it.
But
To the extent they have capacity, we'll be able to work with them, but
add
we don't
additional.
want to, make one provider's limited capacity prevent us from being able to serve patients
So
in that
did we
area.
believe, I guess, that they were gonna have more capacity, or they lead us to believe they're gonna have more capacity than they did, or?
We thought that they would have more than they turned out to have. So, I mean, we still certainly want to work with them going forward to the extent they're able. But there are several other providers that we've started conversations with to add them to the network.
Were they just way off on their estimates of what they would be able to do for us?
I don't have that detail, unfortunately. I can find out more about that for you. I think this is a good example of some of the challenge with contracting with
Right,
providers that typically don't serve our population.
right.
It comes with other challenges, and sometimes our patients unfortunately aren't their priority.
Who is this?
So that particular provider, I'm going to have to think of who that is. I want to say it's Austin Geriatric Specialists. But there are two other groups that we're in conversations with now, one of which actually serves our patients through the Hospice Austin program. So they've got a little more experience working with our patients and some of their unique challenges.
I would like some more detail on that, if
Understood.
you could. I understand that you
I'll be happy to
don't
follow
have
up.
it at your fingertips, but that would be good to have
Yes, ma'am.
on what exactly has happened with that provider and what they had proposed or budgeted that they would be able to do for us versus what's transpired.
Sure.
And then the consultation services, was that just an estimate and we didn't need as much?
So that budget consists of two different things. One is the platform that I think you all have heard about related
Right.
to referral management and e-consults.
Right,
Two things happening there. One is due to some of the changes related to the CCC, that's now going to be a central health procurement and contract.
okay,
The second thing is with community care, looking at a new EHR, that's opened up some other opportunities for us. So we're working with Jason's team to evaluate
Okay.
those opportunities before we finalize anything on our current procurement.
okay. Thank you, appreciate it.
Any further questions? Seeing none, Thank you, John. Thank you,
Thank
Lisa.
you for your questions.
Thanks.
And please stay up there, Lisa. You come up next again.
Now I get to run.
Very popular, Lisa.
Agenda item 7, receive and discuss a report of the preliminary September 2019 financial statements for Central Health. Ms. Owens.
Okay. So just a few highlights. In September, we continue to have good tax collection. We're at $15 million in additional tax collection. We did have a member payment to the CCC for $11 million. And then the other big highlight I'd just like to point out is the LPPF kind of got up and running in August, and we did, you will see that on our financial statements here, but we did make a Performance Year 8 IGT in the uncompensated care program through the LPPF of $13 million. And so when we get to the balance sheet, I'll talk through where you can see those restricted funds on the balance sheet. So again, going into our preliminary numbers for year end, our total current assets are $16 million year over year higher. That is mostly going to be in our tax revenue. As I mentioned, we collected about $15 million in additional tax revenue. And also timing or IGT, as I just mentioned, the uncompensated care IGT was not made by Central Health, it was made through the LPPF. And so that is a timing year over year. In the restricted cash and investments, an additional $32 million this year. You'll see that the majority of that is our investment in the Sendero surplus debenture of $20 million. That was in December of 2018. And then you'll see the $12.8 million of restricted cash and investments for the LPPF. And those are funds that are being held on behalf of the LPPF. We mentioned earlier this year just a few small changes to the capital assets with the addition of the purchase of a piece of land, as well as some construction projects getting started. We have a little bit higher, we have $1.4 million in construction in progress this year compared to very little last year, so our projects are getting up and running. Total assets of $347.5 million. Looking at our liabilities and net assets, just a couple highlights here. And these are going to look really different when next time I see you, when we see October and November. Very different. However, accounts payable is higher over last year. We are with the reproductive and sexual health program. We have a lot of healthcare delivery that is being delivered, a lot more healthcare delivery being delivered through Central Health. You'll see more of that next year. So that increase is due to healthcare delivery being accrued there. And then, as I mentioned, we have the restricted cash for the LPPF, and then we have the funds as a restricted liability being held on behalf of the LPPF of that $12.8 million. So our total liabilities are just $27.6 million. And then our net assets are $319.9 million. Again, 347.5 liabilities and net assets. Just quickly walking through the sources and uses. Our property tax revenue for the year is at 100%. We are very close there. We did have about $100,000 in tax collection and then year-end reconciliation just to true up at the end of the year. So our total year-to-date is $197.8 million in tax revenue. Lease revenue at just $13.2 million. And then other revenue, that continued to be good performance in our investments and interest and then market adjustments. So total sources as of September 30 are estimated to be $270.2 million and $198 million spent on healthcare delivery. I'll go into more detail on the next couple slides. But looking quickly at the administrative program, we were at 90% of our budget for salaries and benefits, just 24% for consulting. As you know, We plan many times, the timing on the projects that we're working on are unknown, and the needs of the organization, but $250,000 in consulting estimated, about just under $800,000 in legal fees, and then other purchase goods and services at $1.2 million. Total, 69% of our administrative budget was spent, is at $6.4 million. So our total uses with tax collection are 206, leaving excess sources over uses at $64 million at the end of the year. Looking at healthcare delivery, we did not have any IGT through Central Health in the month of September. Excuse me. We do have an estimate for primary care. That is currently just our contract with Planned Parenthood. Those funds were budgeted in the sexual and reproductive line that's down below in service expansion. As you know, we lifted up a more enhanced programming this year. We had a member payment to the CCC of $11 million. And then total expansion funds, that includes the sexual and reproductive health program as well as workforce development, totaling $136,000. Our healthcare delivery operating costs are our departments that provide healthcare delivery services or support the healthcare delivery services, such as eligibility and enrollment. Our monthly expenses were approximately $827,000, and year-to-date at 69% of the budget. I would just highlight, we have expenses associated with the LPPF, and as the administrator have a $150,000 reimbursement. That reimbursement is in the other services and purchase goods, but you'll see that we're over budget in legal fees. Again, for the LPPF, it's just, it is not matched up line item by line item, but it is in the other services and purchase goods. So those expenses were offset by that reimbursement. On the campus redevelopment, about $554,000 were spent in September, and a total of just under $5 million year-to-date, as our projects are starting to move forward in that area. And then ACA enrollment and subsidy, we continue to support both the CHAP and the ACA high risk through Sendero. Again, total healthcare delivery for the year is estimated at $198.2 million. So with that, I can answer any questions.
Managers? Chair, Vice Chair?
Yes, you mentioned on the balance sheet, the funds held for the LPPF.
Mm-hmm.
Since my understanding is those are just passing through, right?
Well, we're holding them on behalf, so you'll see an
That's
asset
what I
and a
mean.
liability that
Right.
match.
I understand that.
Yes.
But are we holding those in a trust fund or anything?
We are holding them in our investment accounts.
Are they in a separate?
Yes.
Okay.
They're captured separately, and we're working with Travis County Investments
Okay.
in order to account for those.
Okay, but they are captured separately since,
Yes, and I believe
Since it's a
you're going to
pass-through.
start seeing in our investment reports, you will see an investment report for Central Health, and then an investment report for the LPPF.
Okay.
So that you can see clearly where those are held.
great.
Yeah.
Any other questions?
I know I brought this up during budget time, but I'm just gonna bring it up one more time. We never got information on average salaries and benefits and such, but when we were going through budgets, we were looking at how many employees and what the SWB was.
We're discussing salaries in the CEO's report tonight.
Any other questions? Thank you.
Thank you.
This is an informational item only. No action is necessary. All right. Agenda item 9, discuss and take appropriate action on the update regarding Sendero Health Plans, Inc., including the effect of federal legislative and regulatory actions. There will be no presentation on this or action on this item other than the written report in the board packet. However, Central Health staff are available to answer any questions you have. You have the packet in front of you guys. Do you have any questions for staff? No. Seeing none. No, this is an informational item only, no action is necessary. Agenda item 10, receive and discuss a report from the President and CEO on the Central Health operations and current activities, including A, the fiscal year 2019 strategic work plan and operational priorities, B, an assessment of systems and processes and other personal matters, and 11, discuss and take appropriate action to designate Perla Cavazos as Assistant Administrator. Mr. Giesland and Susan Wilners will be presenting.
Yeah, so, members, I'll start off on this, and we're going to track the CEO's report that's in your packet, and I'll cover some organizational changes first, and then I'll hand it over to Susan, and she will cover some salary data that is pursuant to a discussion that was had as part of the budget presentation. We still need to come back to you to talk about benefits. We wanted to cover salary tonight. I mean, there's a lot of information in your packet that we sent out, and there's a fairly extensive presentation. But in addition to talking about salaries, we also wanted to talk about workforce demographics as well. So I think there's probably another discussion that we need to have around benefits in addition to salaries. But this was a lot of information that we needed to present to you tonight. So. First, I'll talk about some of the organizational changes, and there is an organization chart in your packet. And what I'll do is I'll walk through this chart, and then I will go to a business flow chart, and when you see the two together, it'll make sense. So we have it up here on the screen, but it's better to look at it in your packets. Starting from left to right. And I'm just going to highlight the major changes here. Where you see healthcare delivery division there on the far left, that is formerly what was known as the CCC. So you'll recall as of October 1, the two sides of the house came together, and we changed out ID badges and so forth. We had a celebration welcoming them. I know there were a few of us that walked around with coffee carts and breakfast taco carts, but just to try to make this transition something that wasn't just something on paper. It really is a big milestone for this organization. We're super excited about the additional capacity, and of course, I'm always happy to have one more person to delegate things to, so thanks to John Morgan for stepping up. So, but that's where the CCC is. Continuing from the left side and moving across, you have the joint technology, which still currently reports to me. Human resources, again, that's the same reporting structure. Now, the finance and office of the CFO. So there's some changes, some structural changes that we made there. I think with respect to trying to reduce the number of direct reports, but also to start moving towards taking steps towards what may be an operational division at some point in the future, where you're really syncing up your financial and your operational sides of the houses together. You'll notice that there's some reports lined up underneath the finance and office of the CFO, one being real estate, the other being the deputy CFO, and then compliance and risk management, which is vacant. I do anticipate at some point having compliance and risk management reporting up to the CEO. I think it's important, and this is just a judgment call on my part, that person, after bringing them on board, they really need to be steeped in the operations and the finance of the organization, and that's an onboarding that I personally cannot accommodate. And I think it's just better for those that can to set that person up for success, so that they have a full understanding of all the different compliance issues and risks that we face, whether it's financial, operational, or other. Continuing on across, you'll notice the enterprise alignment and coordination. Looking at this chart, you'll recognize that there is no longer a chief of staff function. And I think to understand enterprise alignment and coordination, I'll come back to this when we talk about governance and deputy administrator.
I am finding this a little difficult to read.
Can't read it.
Thank you.
In fact, I'm finding this more than a little difficult to read. I can't
Possible
follow
that they could
you.
Or
expand
yeah,
it all
can
on
you
the screen,
make that bigger on the screen?
on these
Thank you
screens
for
here.
saying that.
You're welcome.
Yeah, I thought that
I'm
was
not
the
proud.
one.
No, and I've got a screen here and I'm able to
Yeah.
enlarge it and so forth, so
Right,
I
and we-
apologize,
yeah.
members.
Yeah.
I'm not using the paper version of this.
Well, I'm trying to both look at the paper and up there, but I don't seem to be having much success with either one.
Okay.
So I do think it's best if we can follow you.
If it's a touch screen, you can just take just by hand, you can expand the image. So, well, they're working on, we can come back to things that you want to discuss, but the enterprise alignment and coordination function is important because as we started looking at the CCC and the central health portions of the enterprise coming together,
We need to stop. We've lost our quorum.
So it's on, oh, if you stop, never mind.
Sorry, I did that one. Apologies, Mike. Apologies, Mike.
Council, are we good? So the enterprise alignment and coordination function came about because we realized that as we were bringing the central health and CCC portions of the enterprise together, that we also needed to do a much better job at aligning with our enterprise partners. And post-October 1, that's central health, that is Sendero, and community care. And as we start to work more closely together, and we have a series of meetings and work groups that have been set up to do just that on very, down in the weeds operational issues, but also stepping back and looking at larger structural issues, for example, like access to care, which is a group that Jason sponsors, and there's a whole host of enterprise executives from Sendero, Central Health, and CUC working on this, that as we start to work more closely together and align our resources and our planning and our operational issues, that you need somebody that is freed up to float in and out of all pieces of the enterprise. And one example would be the memo that you received in your packet tonight on the expansion of CHAP program to 200 some odd to 500. That involves all pieces of the enterprise working together. And so you have to have somebody that has eyes and ears and can troubleshoot, but also be responsive to the other CEOs should there be issues that need their attention, and I'm not able to need immediate attention, and I'm not immediately reachable. Moving across, you still see planning and strategy that reports to the CEO. You see governance and deputy administrator. Now, this is an important position because, and again, like I was saying earlier, the chief of staff function went away, but you still had those governance issues that require, regardless of what we do, let me back up, regardless of what we do as a hospital district, we're first and foremost a special district created in statute, and we are a political subdivision, we are a governmental entity. And whether we're talking about clinical operations or hospital or social determinants of health, agnostic to all of those things that we do that are outward facing, we still have to have the wherewithal to function efficiently and effectively as a government organization. And this is tantamount to what you see in large urban governments where you have an assistant city manager or in a state agency where you have a deputy commissioner. But also with Ms. Cavazos' connections, like a lot of folks that operate at a high level in an urban, in a city government or in a state agency, you also have a lot of government affairs duties as well. I know that when I was a deputy at TDI, I was down at the Capitol a lot. So I think that having somebody that understands governments and how they're supposed to work, but also being that voice and that interface with the other governmental entities is a good and strong functional alignment of those skill sets that are necessary. And then moving on, I'm sorry, I skipped one, I need to come back to it. Development and community resources. Obviously, that's vacant at this point, and I think that, with Mr. Wallace's departure, we need to step back and take a look at, okay, what is it that we need to be doing, not only to diversify as an executive team, but really rethink, how are we setting people up for success in terms of community development work. And that's not just locating clinics, it could also be programs, it could also be unique partnerships that are born through conversations like the Eastern Travis County Collaborative, but making sure that somebody that has that executive presence, but understand how all the pieces need to fit together, whether it's real estate or programs or partnerships, really driving a lot of that activity and the way that it needs to go to meet the community's needs. And then again, jumping to the far right, you see communications and community engagement. That's going to continue to be the hallmark of what we do around everything that we do, is really getting out there in the community, and not just saying, hey, here's what Central Health is up to, although that's a key part of it, but making sure people understand the resources to connect with care and the resources that we have available, making sure that we're connecting with people in culturally appropriate ways, making sure that we receive feedback on what it is that we're doing to make sure that we're headed in the right direction. So again, that's going to continue to be a critical part of everything that we do. Two other quick issues on the org chart that I wanted to point out. You see the CMO, and the CMO reports to the Healthcare Delivery Division, but then there's also a dotted line. On a day-to-day basis, you need the CMO reporting to the Director of the Healthcare Delivery Division, because there's a lot of just day-to-day decisions that have to be made quickly and on the fly, and there's also some administrative and management responsibilities that individual has that I couldn't directly oversee effectively on a day-to-day basis. However, with the newly enacted authority to hire physicians, we have to set up a medical executive committee, and so there's an ethical issue here that, not just organization chart, but there are ethical issues that would compel the CMO to be able to have access to the CEO and ultimately the board of directors, the board of managers as well. So that's why you see the CMO in two places. Dual reports, it's not anything new in organizations. You see those, we just have to work out the specifics of that. And I think as we look to fill that chief medical officer position, that's going to be first and foremost in terms of understanding, here's how that function is to be performed and here's how that dual reporting will work. So with that, I want to jump down to the two boxes that you see there, and these are currently working teams right now. One is called Platform, the other one is called Finance and Operations Alignment Team, or shorthand FIOPS. Think of the Platform group, and it'll make sense when you look at the business flow in the following graph, is there has to be a first cut. So there has to be, in doing research and different organizational styles and structures, having executives that are responsible for report out on a specific strategic objectives. And you'll notice those three objectives are what you all had adopted prior year, and you've carried those forward into this fiscal year as outlined in the budget resolution that you all approved. Having someone that is directly responsible for those report outs. They may not be doing all the work, per se. Obviously, these are enterprise efforts, but having somebody that has line of sight and understands all the machinations, one, it makes it to where you're not necessarily always going to the CEO to put together these types of report outs. And I think it also goes to what you all pointed out in my evaluation is make sure you have subject matter experts coming in, talking to the board. So I think that this, again, continues to bring those individuals forward to the board. And you'll notice also under Platform we have Central Health Enterprise Operations. and I apologize, I know I'm running up on the 10 minutes.
It's not you, it's their discussion.
Okay.
It's our
Discussion. All right, thank you. On the central health enterprise operations, we didn't want to look at operations, whether you're talking about joint tech or HR or administrative support, as just a thing that's done on the side. That needs to be elevated in importance, because as we look forward to how do we improve our organization, our culture, our skills and our talents, making sure that those central health enterprise operational issues that we identify as management are on par with other outward-facing strategic objectives. Because you can have all the cool outward-facing strategic objectives that you want, but if you don't place a priority on improving the organization, then it'll be seen as kind of a one-off thing. And I didn't want that to happen to us. So now, I'll come back to the platform group when we get to the business flow in the next page. But the finance and ops team, this is where the rubber meets the road. This is where those individuals that have execution authority, have staff deployments that they can use, where they need to bring business cases forward, where you need to sort through various risks that face the organization and how do we control for those risks, when we sort through resource allocations if there's competing projects and deadlines. This is where you come to this group to work through all of those. Now, there's probably been a total of maybe 3-4 meetings, I think. As this group begins to mature and you get in a rhythm, and this is the key part to it, you get in a rhythm in terms of the things that you work through, you'll start to see greater efficiencies over time. And I think it's, having these working groups are essential, because if you try to take that whole organizational chart up there and get them together once a week to work through anywhere from 10 to 15 decisions, it can be slightly unworkable at times. And I've said this before, sometimes it's better if the CEO is not in that finance and ops meeting to allow people to work through their issues, given their subject matter expertise. The next team that I want to point out is external affairs, and this is a team that steps back, independent of anything that we may have as projects. Not that we don't support those projects, but stepping back and just looking at the operational environment. This is a team that Ted convenes, but what's going out there, big picture? What's the situational awareness that we need to be aware of? Things that are in the media, or things that we know that are coming through government relations. Issues that the board members have raised, for example, that could have some type of external impact to central health. We make sure that we're covering those issues. So these are the three teams that will help empower the organization to ultimately achieve the objectives that you all have set for us. Now, quickly moving to the business chart, and actually I'll pause there. Are there any questions organizationally?
Yes, if I may. Okay, I see over to, you said 3 teams. I see 2, the finance and operations alignment team and the external affairs.
Right.
What's the third team?
Well, the
you're
third,
talking about?
I'm calling it a team, but it's the platform group.
Okay, so the platform leaders on the left, the platform group. You have on here a chief operating officer. Where does that appear on your org chart that's right above
That
here?
is that's John Morgan, that's the health, and if you notice, chief operating officer, comma, healthcare delivery division
No, I don't see that.
on the platform.
I see that I don't see that on the org chart. It just says John Morgan,
That
Healthcare
is-
Delivery Division.
That is a unique chief operating role to healthcare delivery, because it functions as an operating officer, but it's not an operating officer for the entire enterprise or
Okay,
or central health
I thought you were
proper
naming
even.
2 people here, a chief operating
No.
officer and an HCDD.
HCDD is just shorthand for healthcare delivery.
So
division.
this is John Morgan, okay. That answers that question. And the E's next to some of these boxes, like healthcare delivery, joint technology, human resources, what do those E's
We
mean?
wanted to start identifying, and it's certainly not, I mean, I can make the argument everybody gets E next to their name, but we wanted to start identifying those divisions or departments that had enterprise level impact.
Okay.
Now, we also have other executives that are functioning at an enterprise level. So I'm thinking about Monica, she convenes an enterprise planning group. So even if a department is not necessarily out there directing, for example, central health isn't directing what community care does with its strategic plan, there are certainly executives that are called on to lead groups across the enterprise.
Okay, so that's what the E means. Okay.
So a question, Manager?
As one who's been in administration, I defer to your judgment in terms of how you lay this out. So I don't have many questions. I guess my question, one question is, where's the board on this?
This is just a staff
I know, but
structure. The board sits up above.
But usually on org charts, the ultimate authority, or at least the policy board, is reflected. So is ultimately your goal to speak that there is a board that the CEO reports to?
Yes, we can certainly change this. This was just a staff level update, but I mean, in terms of anything that's on the website or outward facing,
I would just
absolutely
encourage on that, because in the absence of that, one who is not familiar with accountability may not understood that.
Yes, sir.
The rest of them, as I said, it's really your organization to do, so I have no really questions about it.
No, I just had some clarifying questions.
And again, I think when you look at this chart, and it's like the prior org chart, I guess, that we talked about in late 2017, perhaps early 2018. All organizational charts have a shelf life to it. And if you were to ask me 12, 18 months ago, are we going to have this org chart, I would say, well, we might, but probably not. But with all the changes in federal funding and the central health and CCC sides of the house coming together, that necessitated some quick but thorough dives into, okay, organizationally and functionally. You always start with the functions. Functionally, what do we need to be doing? And then the org chart starts to fall into place. So if you were to ask me, is this a 2 or a 4 year chart? I would say maybe not a 4, most likely a 2 year chart, but we're always going to step back and look at our operating environment and see what functions do we need to have. One of the things that we set out trying to do, and I had a number of discussions with the executive team and did a lot of research, just trying to peruse through business journal articles on enterprise structure, and kind of deferring to those that have been in enterprise structures. We weren't quite there yet. And I think we'll do everything we can to continue to support community care in Sendero with aligned enterprise functions, especially at the operational level. But what I was really striving for was to try to create an operational division. But when you look at a true enterprise structure, and if you take like a parent company and a subsidiary, you might have a chief information officer in the subsidiary who reports up to a chief information officer in the parent company. This person here needs to be responsive to the CEO, but we're just not quite there yet in terms of having that type of what is some would consider to be a true enterprise structure. So I don't want to force anything just for the sake of getting something on paper, but I think that's a topic that we'll continue to come back to as we evolve and we look to how do we best support our enterprise partners. On the business flow, this is the next chart that follows the organizational chart. This is fairly intuitive. I know there's a lot of words and it seems like a lot of steps, but I'll hit on 3 points on this. In terms of what we do, it can come from many different sources. The board, in my mind, adopts a budget and a budget resolution with strategic objectives, and that's where I start. But there are also external challenges and opportunities that come up along the way. And I think about, for instance, pay for success. That was not listed in our strategic plan, but it was something that was presented to this organization. And another just might be, talking to board members, individual board members, you have an idea. And you'd like to see some business plans put around this. You'd like it debated or discussed. That's another source of ideas. We have partners that bring things to us. Frontline staff come up with some great ideas about, hey, if we did this, it'd be a lot more efficient. It'd be a lot better for the people that we serve. So ideas can come from anywhere. But then we have to run that through some processes, because I think what was happening when I was interviewing staff on some of the organizational challenges we were having here recently, they said, Mike, it feels like that we go from idea to execute, and all the necessary steps in between, we're just, constantly trying to keep up, if you will, and put things together as the car is rolling down the road. So what this is designed to do is to bring in some thought discipline, but also operational and business planning discipline. And the way I would characterize this is that there's really two check-ins. And so let's just say that a board member has an idea and says, this is what I want to do. And what I would suggest, with the budget resolution saying, to the greatest extent practical, there will be business cases built around different initiatives. You have checkpoints along the way where first you ask the big picture, does this fit with our mission? Is this a good allocation of human and financial capital? Is it consistent with what the board has adopted in terms of the objectives? And sometimes it's not, but it's your call to say, you know what, we're willing to deviate from that for this reason. And you can do that as a board. But there's that first check-in. The second check-in is really at a granular level to say, all right, do we have all the necessary assets in place? People, time, and money. But also I would, and those are the three key assets that you have to have, because you can have a great idea, but if you don't have the people or the money to be able to implement it, it just stays an idea, right? But another lesson that we've learned over this past fiscal year is the dependencies. So for instance, if we want to open a clinic, one dependency would be we have to get permitting. And sometimes that's at other people's schedules, and it's completely outside of your control. So the point is that the reason you take things to finance and ops, and after you've checked in with legal and compliance, and you've got some initial blessing by the board, is to make sure that everything can fall into place as necessary to make sure that if it's a new initiative, we can push it across the finish line, or if it's something that we just have to get to steady state operations, it could be an internal operational improvement that we can get this done. I'll give you an example of an internal operation improvement. Lisa's not here, but and her team undertook a huge task of redoing the procurement processes and the purchasing processes. So there was a lot of work that was put into that, but we had to make sure, can we get this done before we started this work? So that's an example of trying to get something to a process improvement to a steady state operations. But anyway, I won't go through all the steps in this chart, but just remember this. There's two check-ins at a high level. Does this align with our mission? Does it align with what the board has said? This is what we'd like to happen. And then the granular level, which is, do we have all the assets and steps in place to be able to make this happen? And then you have to get through to the initial go. You continue to refine it. You assign project managers to it as necessary if it's a new initiative, and then you execute. I would say, regardless of what in the far left there is the source of the impetus for a certain course of action, we want to run as much through this process as we possibly can. Emergencies or other exigencies may necessitate that we discharge something from this particular process and we just take it up as a quick matter for the board, but and even suggestions that come from the board. We want to put a business case to it and bring it back to you all to say, all right, just eyes wide open. Here's what all is involved with this. Here's the impact. And again, bringing about some more business processes and discipline. So I'll pause there to see if there's any questions.
Ed Jones?
I guess my question is, the flow I follow, and it makes logical sense to me. But in terms, it goes back to my original question with regard to the structure of the organization. So if there's a priority has been identified by the board, this process, whether or not it has these multiple steps, if the board decides that it can be expedited or steps could be moved in front or changed around, is it your understanding that that would still occur if the board decides that is a priority?
Yes, no, and yes, it could, but the board as a whole would need to speak to that.
Yes.
And so like one board member couldn't call me up and say, hey, I want you to skip all this stuff and just go do this.
Right.
I'm trying to pull us back from that as much as I can.
I follow that.
Yeah, and I think that if the board says, Mike, we want you to go straight to execution, okay. Now, there's a consequence to that because we may not have it all put together yet. and we'll do the best we can to try to fulfill what the board's wishes are. But as a board, you all have that authority to say, this just needs to get done immediately.
Well, conversely, the concern is that if a directives come from the board, perhaps we should give some timeframes in which our expectation in terms of feedback from this occurs, because it could be also, if staff is not supportive, it could be a stalling tactic as well. If they will get back to you 3 weeks from now, whatever. So I think a part of the direction we need to do is to say, okay, we want to expedite this. We want it done with feedback within X dates. And that's the expectation of the curve. Once the board decides to do that, I'm not talking about individual board member.
No, and what I would ask is, as long as the board brings it up in the meeting and says, hey, we want to expedite the business case on this,
Yes.
or give us even just a preliminary take of what all's involved, that would be good, preferable.
Yeah, of course.
So that way the board as a whole, as a majority, is speaking. And otherwise, and it could be any of you, your ideas will be put in the queue with everything else that we've been told to work on.
No, I follow. I'm just saying that I think that's a direction for the board to consider in terms of our
Absolutely.
interaction.
And that's the board's prerogative too.
Any questions? Okay.
Okay. So at this point, I'll turn it over to Susan, and we'll go over workforce demographic information and then also the salary. Turn over there.
Good evening. Hello, Susan Latta Willers, Enterprise Vice President of Human Resources.
Betsy Good, HRIS and Compensation Analyst. Sorry, I'm a little new still.
Yeah, I just recruited her a couple of weeks ago, and she's
Welcome.
been helping put this together. Okay, so there are a lot of slides in your packet. I'm not going to cover everything, but what I'm hoping, what's in your packet is the workforce demographic for the Central Health Enterprise. And then I went ahead and split up the demographics by entity. Also included is the enterprise compensation philosophy and a little bit about the salary structure breakout. And then as far as salaries, I'm going to be sharing with you the enterprise salary averages by grades, race, and ethnicity, and then also the Central Health proper salary averages, grades, and by ethnicity. So with that, I'm going to go ahead and, if you don't mind, I will share with you the enterprise demographic category slides. If you all want me to cover, you're going to have Central Health proper, community care, and Sendero. You can review them on your own, or I can go through everything. It's up to you. But
Are they
here,
part of the deliverables?
I'm sorry?
Are they part of the presentation?
Yes. So this is the enterprise race and ethnicity category. When we ran this report, we had 1,036 employees enterprise-wide. You can see in the report that the Hispanic, Latino population of our employees is at 55%, and the white population is at 29%. The gender category, we've got 84% female, 865 of them, and 16% male. We have 3 individuals that did not select either female or male, and it didn't really register a percentage, but there were 3 individuals. It's there on the left-hand side. Age, we went ahead and provided you with the age breakdown plus the generation type. And so you'll see that the majority of our workforce are between ages 25 to 44 years of age. Those are our millennials and Generation X folks. And then 19% are baby boomers. Any questions on that? Do you have a preference if I can now move on to the salary piece, or do you want me to cover all of the demographics for the entities?
Well, I guess my question is, so on the not so much salaries, but do you have these classifications by, I mean, these demographics by positions, meaning executive, mid-level, front desk? Do you have those? Are those part of this presentation?
They're not part of the presentation, but we can definitely give you the EEO4 that we filed in September, and it gives you all of that information as well.
By race and ethnicity?
Yes, sir.
Okay.
Okay,
I think that would be helpful to have.
perfect.
I think everybody would want that.
Okay. So I'm going to skip the central health demographics, community care, and Sendero. And I'm going to go ahead and get started with the,
I'm assuming that what you're skipping is just a summary of what you've just gone over, is that
it's
fair?
individual entities.
Yes.
Yes. So the central health philosophy, compensation philosophy and structure. In 2007, the,
Sorry to.
Go ahead.
Mayor.
Sure.
I know it's reaching a lot of time, and there's still a lot of information to go through here, but I would encourage the board to at least look at Simple Health proper on the demographic information. Again, that's something that you all were asking about, but I would really like the board to focus their attention on just the Simple Health proper. We can always come back to the other pieces of the enterprise.
Okay.
but
Is there any
if
reason,
that's it's acceptable to the.
is there any reason we should just focus on, just on that?
If I was a board member in your shoes, I would want to focus on the entity that I was a board member of.
Well, I'm assuming that the enterprise is part of what we have some,
It is, it's just a breakdown by the, I mean, I'm not trying, it's not a, just, this information is here, and I would
well,
hate to miss
particularly
the
for
opportunity
community
to
care.
engage in.
Community
dialogue
care
about it.
particularly is where the rubber meets the road in many of our services. So I would think it'd be important for us to know the reflectiveness of our clientele to our population. And central health is not the persons out there doing that for the most part.
Just,
But Central Health is the leadership organization over community care, and it doesn't seem to have a reflecting demographic of community care. Does that make sense?
No, I'm agreeing
Yeah.
that central health is an oversight. I'm just saying is that when we're talking about equity in a community, we want to make sure our
The
staff
front
are
line.
reflective of that.
True.
And if we are just going to focus in on the administrative part of that, we sort of forget that piece. So I'm just saying that I think we should look at both, not just, I'm not suggesting
Okay.
we spend time doing it tonight, but from a policy point of view, I think we need to look at that.
but we would like to bring it back, so you can see, get into some detail on the other aspects of the enterprise. But, okay.
okay. So in 2007, the Central Health Board adopted a compensation philosophy. The three main points of the philosophy is to pay competitively in our industry labor markets, to be equitable both internally and externally, and to ensure that the salary program is based at the 50th percentile of the industry labor markets. That's in a nutshell. It's a pretty long philosophy, and I figured I'd just pull out the three main points. The salary structures for Central Health are divided into three. We have a non-exempt structure, meaning the hourly employees. We have an exempt structure for non-management positions, and then we have another structure that's exempt for management and executive positions. Just a little bit of, this represents the structure, how it's, the spreads between the grades. And so from grade to grade on the non-exempt structure, we have a 6% spread. And then from minimum to maximum, there's a 50% spread within each of those grades. This is only for the non-exempt and the exempt non-management positions. The exempt positions have a 10% spread from grade to grade and a 60% spread from minimum to maximum. Any questions on?
Can you just give it, so if somebody was making, let's say, $100,000, that was the minimum, 160 would be the maximum?
Correct.
Okay.
I also included just an example of the market study and position placement. Would you like for me to go through that as well? So since 2012, Central Health has utilized the Economic Research Institute survey tool. It's a very reputable tool. The parameters that we search for are healthcare and government, county, parish support, not-for-profit, and we also search the Austin region. I provided you just a little bit of the actual peer group that is in the Austin region. Sometimes it goes outside of the Austin region, and but this is just a quick glimpse of some of those peer groups. When we do market reviews, HR conducts the survey analysis, and then we place the positions. We compare the current grades against the median of the survey data. So for example, and I apologize, this is pretty small, I can barely see it myself. On the left-hand side is the economic research data that we pull, and this is for an administrative clerk position. And you can see that to the left-hand side, it's in gray. There's a mean amount of, I believe it's $18.33. On the right-hand side, this is just a sample of what the salary structure for non-exempt looks like. On the left-hand side, you'll see the numbers 11, 12, and 13. That's grade 11, 12, and then 13. Then you'll see the title, administrative clerk. To the right of that is, you'll see $14 at the top, $17.50, and $21. The $14 represents the minimum of the grade. The $17.50 represents the midpoint of the grade, and $21 is the maximum. So what we do when we're doing the fact finding is we get the mean score amount for that position. We look at where, number one, the position is at currently, and then we look to see which midpoint is closest to that mean in the salary survey. So in this case, the mean is $18.33. We would actually move the administrative clerk from pay grade 11 to 12 because the mean of the salary survey is closest to $18.55. Does that make sense? Any questions on that? And we go through this exercise for every position within the enterprise. Now I'm going to share with you some salary information, and there are a lot of charts in here for your review. I thought I'd go through the enterprise data, but I certainly can go through Central Health proper as well. First, let me tell you that there's certain things that skew the data, and one of them is experience. So when we offer our candidates a position, or when we make them an offer, we really base our offers on their experience, their applicable experience. Also, tenure can, be a factor on skewing the data because the longer you're here, you are impacted by merit increases once a year. And then the third thing is the grade. So what we did is we put grades together just to keep it at a minimum, but pay grade 5 would be a lot less than pay grade 7. So depending on where those individuals fall within those grades could also skew the data. So what we did for you is we took the average salary and we divided it by gender and then by race and ethnicity. And so I'm going to highlight some things on each of these slides, but certainly I can pause for questions. So on the pay grades 5, this is non-exempt information, grades 5 through 7. In this case, all of the both male and female categories showed an average of being on pay grade 7. So when Betsy and I did this and we looked at it, we thought, well, what else can we take a deeper dive and share with you? So what we did is we looked at the data, and then we averaged out the salary grade within each of the groups. And so what I'm going to be highlighting are the average grades within those groups. Because you'll see that, for example, in this case, you'll see that the race of Asian female is at 29,000, and you'll see that white females are at 36,000 average. And so in this case, what we did is every single category here is at an average grade of a 7. And you have people that just started working for the company within the enterprise with very little experience to being very seasoned. So that varies also as far as where they're going to be on the grade. I'll pause just to, see if you have any questions or if I can clarify. Yes.
I just want to make sure I understand. So is this a total, I mean, are you including all across each of those racial, ethnic groups? Is that a reflective of all of those populations when you said 7?
So, for example, I guess let me walk you through this. I failed to do that. On the left-hand side, you'll see the category of the ethnic group and race. And then the second column, you'll see females. So right next to the female column, you'll see years of experience. That's the average years of experience for those females in those categories. Then you'll see the average salary for those females in those categories. Then right next to that, you'll see the column males. So it'll give you the number of males in those categories and with their average years of experience and their average salary. And what we did when we looked at this is all of these categories in the female category and male averaged at a 7, at grade 7, meaning that most of them are getting paid at the higher end on pay grade 7. Is that accurate?
May I ask, were you asking about the overall grouping of this particular data set? Is that?
No, I was talking about individuals, so I think you answered the question I was asking in terms of overall, but so you're saying they're all skewed towards a higher grade?
Towards
primarily
7.
Because of, I guess, length of service or the way they entered.
Correct.
Okay.
The next slide shows pay grades 8 through 11. And in every slide from here on will be the same, with the race and ethnicity females and then the experience and so on and so forth. In this slide, the female category for American Indian and Alaskan showed an average grade of an 8, and the Asian female category showed an average of 10. And I just wanted to show that because I'm trying to pick who's earning less and who's earning more, so just pulling out bits of information for you all. The next slide shows grades 12 through 16. And in this case, the female white category showed an average grade of 15 compared to the female Asian population showed an average grade of 13. The next slide, I'm sorry.
Just one question on 12 through 16. So the 58,233 is reflective of an average of the 8 years of experience for white females versus the one right above it, 2 or more races, I'm not sure what that would be, 9.6 years of experience at 49,000. Is that a
That would be because that category is at a 13, as opposed to a pay grade 15 where the white females are at.
And I think maybe what you might be asking as well is the 12 females that are in that group, their years of experience combined are then averaged into the
Right,
8.6.
right.
Okay.
And that's
Forgive
what
me.
that's reflecting?
Yes.
Okay.
So, grades 17 through 20. The female white category is at an average grade of an 18. The male African American category also is at an average grade of an 18.
It would may have been helpful if you'd put the average grade on here, because that's, you have to calculate, or you have to assume that.
Yes, and we thought about that after we submitted our presentation to Emily and Brianna. So we can get this data for you. This is the enterprise exempt non-management position or scale, meaning that these positions are exempt, but they are not in a management position. And these are grades 16 to 21. We currently do not have any positions in grade 16. The Native Hawaiian category for male and females average a grade of 21. The next slide is grades 22 through 26. The female Asian category here, it averages a grade of 26. All other categories average a 23 or a 24, which you can see the difference in the average.
Can you go back one slide?
Sure.
Because or no, go forward one slide. What are the pay grades for the Hispanic, Latino, female versus male?
23 for the females, 24 for the males.
I'm just seeing a lot of things where it appears that men are paid more than women repeatedly. And I don't know what the difference in the two pay scales is, but I can see that the women have collectively more years of experience than the men. And have y'all done an assessment? And I'm not saying y'all haven't, I'm just like, and noticed any peculiarities about male, female, white, non-white? And do you have some feedback on that? Because just at first blush, and without knowing the pay grades within these, and I know this is a range, but at first blush, especially when you're in the non-exempt area, it seems like men are paid more than women and white is paid more than non-white.
Yeah.
Actually, that was examined at great length, and there is absolutely no relationship between gender and salary whatsoever across the board, enterprise-wide. There's no correlation, zero. It's not statistically significant at all. As far as race and ethnicity is concerned, there are situations in which there is a relationship, but it is not of such a degree that when other more significant factors are added, such as experience, that significance doesn't go away. So in other words, there are other things that are more important, if you will, in the statistical relationship than ethnicity and race that play a more important role.
It doesn't seem like the numbers share that story that you're telling us.
Yeah, and I think some of it also is the range in the grades. I think if I would have given you the averages per grade,
Yeah,
it would have
maybe
been.
that's what we need.
Yes.
I think
Yes,
that would be
that's
far
what
more
we need.
helpful.
Yeah,
I agree.
this is the first time we present this data, and so we definitely can get, can continue.
Okay, so let me ask you this. What keeps somebody at 23 rather than getting promoted to 24 when they have more years of experience than their male counterparts?
So 23 is is not, doesn't, you don't move up a grade because of your experience. You move up a grade because of the position you take.
Okay.
Okay? So the difference is the position itself. The positions in 23 are different than the
Because
positions.
I think that would also be interesting to see if more men are, and I'm not saying they are, I'm just saying with the data we're presented with, I'm seeing some things that cause me concern. And it would be interesting to see if men are paid at higher pay grades than women, too. I'm just saying, it just,
Yeah, well,
and.
But my question goes somewhat to that, and it's not so much, well, I would agree with race as well as gender, but the question is, this data seems to be skewed because of the because of the grades. Meaning someone could have spent many years at grades lower who are white, but they show up better because perhaps their salaries are low, or conversely. So I'm wondering if years of service or the multiple salaries that they make at these different grades skew what the race or the gender perspective is.
So every grade has a maximum, and once you hit that maximum, you are maxed out. You no longer get any increases until you move out of that position, move to another grade, or the market moves that position to a different grade that has a higher maximum. So you could be here for 20 years, and if you stay within that position, you're only going to earn, for example, that maximum of whatever that amount is.
And if you're of a certain race, and that race is predominantly in that category, and that category stays at that rate, whereas others are brought in at higher rates, that's going to skew the picture of the grades, will it not?
Yes.
And that's where I'm sort of trying to, I'm trying to get at.
When to be fair, I think that skewed is probably a more pejorative term when you look at the data overall, just because I think that the process that has gone through is very systematic and does not involve, I mean, this is reporting on what the factors are after these people are put into the positions, not that these things were taken into account. Does that make sense? Am I?
Yeah, but I know we're not going to spend all night going through this, but I would I wouldn't necessarily concur with that philosophy, but I hear what you're saying as well, because I think that numbers make a difference in terms of skewing, and certainly number of positions, when you lump them together, based upon how people got to position, how long they've been in position, also goes into factors that will skew what you're presenting there, is all I'm saying. But we can discuss it at a later time. I just want you to be aware there are some biases in the data that could be reflected by years of service in a position, especially if you entered one, you've been locked there, and you don't have the opportunity to move up, or not offered the opportunity for whatever reason.
Question.
Yes, so I think I've heard requests for, and I know this is your first time to present it, it's a lot of
It is,
data.
yeah.
But two pieces of refinement that would be helpful to us. One is those categories we're speaking of, and I agree, I think that'd be really helpful. And the other was on a chart back here, and I'm trying to remember what it was. You were showing the percent
Average grades.
one way and not the other. Percent included and not percent excluded, or whatever it was. There was something else back there. That's what I was trying to remember.
The average grades is the only other thing that I have, and then I was going to add stats.
What was that?
The average grades.
Oh, that's right. You all want me to add the average grades to the slides?
Right.
Yes.
Right, okay. And then, and I know we do need to move on, but I think there are some, when you were talking about the factors that influence the statistics, and some of this is historic, and it may or may not be pegged to the ages that you were looking at, those age ranges, but certainly with socioeconomic status, which in this country there is some relationship to socioeconomic status and race and historical racism, right? That this country has
Still has.
yeah,
I'm willing to say
and going back in history, we know of some causation. And so when you look forward, then I'm wondering if in some of these older age demographics, you're going to see more stagnation or more people not at some of these higher levels because they were in either racial or socio-demographic or the combined relationship where they didn't get the kind of opportunities for education and advanced degrees?
If I may.
Sorry, that was long-winded. I was just trying to get there.
Not at all. If I may, actually, it was interesting because I think that with all of that in mind, I wanted to look at the data, kind of norming the socioeconomic status and race and ethnicity and so on. So seeing the proportion of, say, Hispanic, Latino employees operating, employed in lower level positions, grades 6 and 7, we'll say. I looked at that. There was no relationship within those two grades as far as salary goes, as far as race predicting salary, race and or ethnicity predicting salary. And then I looked at the rest of the data with those two grades removed. And again, the same thing happened, that there was no relationship between race predicting annual salary. So there was, once you controlled for the socioeconomic impact, if you will, then yes, there is, again, a relationship. So. And that can be provided as well.
I can tell you that throughout the, with the different executive groups that I work with, we look at this data every year to determine, where, for example, our lower paid positions are at and where we want them to be because of the, high cost of living here in Austin. And so we take these things into consideration. I'm also going to talk about a program that we're introducing later in a few weeks that hopefully will open doors for some of these folks. So this is the grades 29 through 33. And just very quickly, the female African group is at an average grade of 32. And the others were grades 33, average grade of 33. Grades 34 through 38. Native Hawaiian females are averaging 37, grade 37. Asian female and males also average 37. And the other groups average 35 to 36.
I do have one more question. Like, if you go to that, somebody has 20.7 years of experience, how, when Central Health hasn't been around that long?
That is actually, so Central Health will pay up to 8 years of past experience, 8 years to bring a person to the midpoint. So that is taken into consideration, and then the tenure that they have obtained since being here.
That is prior experience in the field.
Exactly.
Okay.
Grades 39 through 43. In the male African American category, the average grade is 43, white female and male 37. And that is the enterprise data. Would you like me to walk you through the Central Health proper, or yes? Okay. So Central Health proper, because of we only have 54 non-exempt employees throughout grades 5 through 17. We lump them all together to give you this chart. And the Hispanic female average is at grade 11, and males 12, and Asian male is 18. Within that range. And this is, it starts really low, and obviously pay grade 17 is really high, but once we give you the per grade data, it'll make a little more sense to you. Grades 18 through 20, all of these categories averaged at a grade 20. We did not have any males in this category, just females. Grades 21 through 23. The African American category for females average a grade of 23, Native Hawaiian males at 21. Grades 24 through 26, white female category at an average grade of 25, Hispanic males at a grade of 26. Grades
What's the white male grade? Average grade?
24.
And the white female is 23?
The white female is 24.
So they're both 24?
Mhm.
Okay.
Grades 31 through 35, Hispanic males averaged a grade of 33, white females and males 35. And the last category is grades 36 through 39, and then we have no one in 40 through 41, so it's 36 through 39, 42, and 43. Again, African American male, grade 43, Asian female, grade 39, and the ones in between are 40. And we even have one Hispanic male is at 38. So before I talk to you about turnover, I would like to share with you some next steps, and also I talked about this program. This fiscal year, we will be investing in a software that will help automate all of this for us as opposed to doing it manually. And it's going to automate the analysis. It's going to be able to detect any pay equity gaps, and it will help us during the market review and projections as well. And so a little bit of history. In 2015, we actually did a pay equity review, and we adjusted salaries as needed. Since 2015 to now, we study the market on an annual basis, and we've provided several market adjustments through the years. We will continue to do that, and we're really excited about being able to purchase this equipment that will help automate a lot of what we do and manually. I was very lucky that Betsy joined me, because otherwise I would have probably been spending the night here at Central Health. The program that we're introducing enterprise-wide is the Emerging Leader Program. And this is going to be introduced hopefully next week, and it kicks off in January. But this is going to allow an opportunity for our frontline staff to move up to supervisor or management level. We're also going to be working with leaders to redo the job descriptions in the positions that don't require a professional license, for example, a registered nurse. Those positions will require those licenses, and unfortunately, if you don't have that license and that education, you cannot apply for that job. But for those more administrative management roles, we're hoping that when the participants of the Emerging Leader Program go through that program and graduate, that they will, in lieu of a degree, will give them that opportunity to move up. So we're really excited about that. It's been approved by the executive groups at every entity, and we're really excited, and we'll be rolling this out pretty soon. And with that, I'm going to turn it over to Betsy to talk about turnover.
Could I ask one question before we go there? So when you, in your new system, will you be looking and assessing these by individual grades or by group grading, as you've done here?
I have not worked with that software yet, but I'm guessing that you're able to manipulate the data however you want. I mean, they're very sophisticated.
Okay, well, I'm concerned about the manipulation. The question, I guess, is will it be, if, for instance, you want to look at all of these categories by individual grades, not grades 29 through 30?
Sure.
Will that be able to provide that information?
Absolutely.
Okay.
Yes.
You can even do modeling from it.
Okay.
Pretty sophisticated.
Can you pull out outliers as well?
Yes. So the turnover on the screen is incorrect. We put a document in front of
Yeah, I
you.
was wondering about that.
Yes, so please look at that one instead of the one on the screen.
I'm just gonna get rid of this one.
Yeah, the one you're provided is the correct one.
Oh,
Forgive me
excellent.
for the one that's on the screen. The turnover data is the terminations themselves. You'll see in the chart at the top left. They are cumulative. So
Wait a minute, which one is correct? I'm still not.
I have the one that's on the
There's a
screen.
single one that was.
The
passed.
single
Yes,
sheet.
yeah. The single
Sorry
sheet.
about that.
Say 12, 17, 18, 15 across the.
Yes, is that one correct, or what's on the screen in front of us?
No, let me change that. That is not
Yes,
correct.
Thank you.
Yes,
Okay,
sorry about
so,
that.
Yeah,
Do not look at that one
you
yet.
understand why I was a little confused.
And,
Okay,
and
so,
forgive me for that one, yes.
okay, so let's get rid of that side. Okay.
So as far as central health, the terminations listed in the chart are cumulative. So and it does say Q1, Q2, Q3, and Q4. That is simply because it's being annualized per quarter. So this year, or I guess last year you could say, 15% total turnover. And going forward, we will provide the turnover current as it is, as well as a rolling back 12-month period to show where we are, as well as the fiscal year to date annualized, so that, we're comparing apples to apples. So, any questions about that?
Do you have that, or is that able to be calculated by race and ethnicity?
Turnover?
Yes.
We could.
Yeah, certainly. It would be more effective with organization-wide, just because, the sample size would be very, very
Yeah,
small.
that's why I was saying that. I don't know if you can do it, but particularly the termination ones, agency-wide.
Sure, yeah, absolutely.
Okay, thank you.
Yeah, we can do that.
Is this just central health or is this the
Yes.
enterprise? Because I thought central health, head count doesn't necessarily mean FTEs.
Correct.
All right, never mind.
Right,
All right,
right.
got it.
And the last slide provides you with the reasons for departure for the 21 folks that exited in fiscal year 2019. I placed them in these individual categories. 2 individuals did not return from a leave of absence. 1 returned to school full-time and resigned. 1 retired. And 3 were involuntarily terminated, 1 for performance and 2 for policy violations. 2 left for personal reasons, and 12 found other employment outside of the enterprise. And that concludes our presentation.
Excuse me?
So first, Susan and Betts, I really want to thank you all. I think this is our first foray into pulling together not only salary data and demographic, but turnover data and presenting it. As you can see, it's pretty comprehensive. I think, we've got some follow-ups here, and we still have some more issues to cover here under this reporting item, under this agenda item rather, but I think, we'll certainly bring the follow-up items here, but I'm gonna come back to a question that I asked a couple of meetings ago, and that was, what's the board's thoughts on this? Because we're operating on a philosophy that dates back to 2007,
Yes.
and a lot's changed since then. A lot of analytics have changed since then, the demographics have changed. And anytime you make a change like this, you really need to step back and see, okay, well, what is the overall philosophy on this? But then ultimately, if there is a change, what all is involved with that? So it doesn't just affect Central Health proper. If there's going to be an enterprise-wide change, obviously that may affect community care in Sendero, et cetera. So I would just throw that out there for you all to consider. But I think after we come back with these follow-ups, I'll need to come back around to, what are the board's thoughts at this point? What do you see as the end game on all this?
Mr. Giza,
Yes.
I have one other
Yes.
thought on what you just said, and that is, how often do we do these salary comparisons?
You mean the market reviews?
Yes, the market reviews. thank
Once a
you.
year.
Once a year. So I looked at that list briefly, there were a lot on it, but do we include other, we look at Austin and around the state? Where were you saying those comparisons were drawn from?
It's Austin region, but when, through ERI, they require a certain amount of peers to be able
right.
to give you that information. Sometimes they're not able just to give you Austin because there aren't enough.
Well, there aren't any other
peer groups.
hospital districts, for instance, in Austin.
Right, so they'll go outside of the city of Austin into other areas, surrounding areas within Texas.
So I think a question just for the future would be, are there any entities that don't seem right to us in this mix, or are there entities that we think should be added to this mix? I realize that, you know, we operate differently than most of the other healthcare or hospital districts in the state of Texas because we do not own and run the hospital. Nevertheless, there are some positions that are common. Should we be looking at that? Are all these appropriate? Should we be looking at high-level executives or legal counsel or others, whatever it is, in other, you know, governmental entities such as, you know, a large city? I'm just going to throw that out there because that was something that occurred to me that I think we will want to, potentially the board may want to revisit in light of your question you just had, Mr. Giesel.
And I follow, I mean, I totally agree with you on that because, I mean, in looking, and I don't know if this is a comprehensive, but I don't see, I mean, I see HCA is on here, and I see Team Health, I mean, but I don't see like Parkland or Harris County or.
City of Austin.
Or City of Austin, right, exactly, City of Austin. I'm seeing some.
And it couldn't
some
be the
big
whole
names.
city, but if there were comparable positions.
So,
Anyway,
and, you know, it's,
Just-
yeah, I'm with you.
just something I wanted to
yeah.
put out there when you asked. It was something that occurred to me when I had looked at this list a little while ago. It's something we may
The
want to
ask would
visit.
be that it would not only be presented, but it would be matrixed, so we could compare the cities
I
and
would
the
think so.
positions, yes.
I mean, you know, Anthem is on here.
I know we
It's, you
need to keep
it's-
moving, but wanted to just put that out there.
I'm sorry, what is it that you mean by matrix?
The position, the classification, the title, the salary, all
Of
of
the
those
other
things.
entity.
All of the other entities and compare it
To ours,
to other districts.
Yeah.
which is done when they do that comparison.
You mean in the enterprise?
No,
Or the
no,
entities that you
comparing-
work?
The other
comparing to
entities.
the
Oh, I
Yeah.
see. So that is not the way that the data is shared. I'm sharing the peer group with you, but we don't know when that ERI example I showed you,
Right.
I don't know which participants are in that.
Yeah, that's actually illegal.
Yeah, so I can't get that data.
Right.
You know, it's whoever participates in that survey and pays, you know, because we pay some money to participate. But we can't say we only want Parkland, or we
Right.
want Parkland and HCA. It's whoever is within that region if they participated.
So if there are entities that we see that we would like a comparison of, we would just have to do that on our own?
I don't know where you would get the data for that entity, unless the entity is willing to give it to you, like to us.
Well, some of it's
Right.
publicly available.
Yeah.
Public available, but you
It-
still
it's
have to go
publicly
in and
available.
manually search it, because
Yeah.
like Parkland's not gonna,
Right.
they're not gonna do a salary study for you, you just turn around and give it to you.
But the City of Austin may have
We
that,
would
I
have to
don't
go
know.
in and figure that out.
Correct.
Well, we can discuss it more later.
So hospital districts are not required to provide that information, is what you're saying?
They're public entities and
Yeah.
they're
Yes.
required to provide it, but they're not gonna tabulate it for you. You still have to go in manually and say, okay, if you have a vice president of HR, what's
Right.
the Parkland equivalent for an enterprise
Yeah.
vice
I think that's what
Right.
we're asking.
Yeah, we'd have to
Yeah.
do that
But
ourselves.
it's a
at
manual
some point.
exercise.
Yeah.
Right,
no,
but
no.
we may need to do that on some entities.
Okay, so members, all right, so let me, if I may come back to this. If I know what your end game is,
We want to make sure that we're paying reasonable salaries and that, I mean, we are fiduciaries of the tax receipts we receive. That was my initial concern. And I'm looking at these and we are not an HCA. We are not a Universal Health Services. We are not an Anthem. There are a number on here that I could go through and say, we are not that, not Team Health. I mean, these are entities that are much, I mean, multiples larger than we are. And multiples probably more, you know, sophisticated than we are. I mean, Tenet is on here. I mean, do you know how many hospitals Tenet
Yes,
owns? I
and-
mean, it's just,
and I think too, if you were to, again, looking at just the market data, and somebody could leave here and go work for another healthcare entity. Now, it could be a hospital system, could be anywhere, and make a lot more money. And so we know that we're not able to match those salaries, but still, I think to have that included in some kind of database and some kind of calculation to figure out, you know, what is it that we are competing against? Not that the idea is, let's go match what HCA is
That we're gonna
paying.
lead the
We know we
salary.
can't do that, but at the same time, I mean, you're absolutely right, is that we are not that, but people could still leave and go work elsewhere if they wanted to.
I hear you, but I'm also, you know, on
Well,
some
we're-
level do know what
We are a
we've paid
public
our,
agency,
like,
though, and
that's the other
and
thing
so
we
the
are.
question remains is, I don't see why we should not be able to compare ourselves to other hospital districts in Texas as a minimum, not, and go from that.
So there's, I'm sorry, go ahead.
And I was saying is that, yes, you're right, people could leave here and go other places and make more money. But people also who are in other places may be searching for opportunities who have similar skill sets, who would be wanting to work at it because of their own mission. So that argument can be made either way.
So there's two end games here that I hear. One is, are we being good stewards? Are we paying unreasonably? Two, how do we stack up against other hospital districts?
Correct.
Okay.
We are at 10 minutes on board questions.
I guess, let me just say, and we've had these discussions before, but frankly, it may have been before you came on board. You may remember them, Susan, and we're kind of a unicorn. How do we determine some of our comparables? And are there entities missing from this mix that we would want to add? So I'll leave it at that, okay?
So, Counselor, would it be permissible to finish the answer to the question, or does there need to be a motion to lift the 10-minute?
So the 10 minutes is for the board's question and discussion. It's not for responses to questions.
Okay. So again, my question will be, okay, that's what you'd like to see as an end game, but then what's the action point? Let's just say it comes back that you feel like we are overpaying Manager Oliver, or no, we need to be in line on the median of what hospital districts across the state are paying, or maybe what the larger urban ones are paying. I'm not sure what you're thinking about.
Not rural.
So,
urban ones.
are you looking at wanting to proactively adjust the salary schedules, or do you want to go
Look, I don't know what
look
the
at
answer is
philosophy?
right now, but I think we need to see what we need to see first before we can say what we think the course of action would be. I think it's premature to even, I mean, to ask people to go backwards, no, that's, I think that highly unreasonable of us.
So I have to say something on behalf of staff. We're going to be responsive. We're going to give you everything that you've asked for. But as of right now, this creates a level of uncertainty for a lot of people, because now they're wondering, what's my career trajectory going to be like? Is it worth staying here? And I'm not talking about at just the executive level. I'm talking about all across the enterprise. So please, members, I'm going to beg you, be very, very careful with how you proceed through this issue, because I would hate to start losing people because they feel like the board's out to get them. Or it's just, no, you're just looking forward, we're going to start capping things. I know that's not what you said, but I've seen these types of situations before where people get real uneasy about these things when they know that what they thought they've planned out as their career trajectory all of a sudden changes before their very eyes. So I'm going to beg you to keep that into consideration.
I think that's totally fair. I really do. I will say that tonight, looking at some things, made me more
There's some
concerned
gaps that we need to close, absolutely.
than
Yeah.
my
Absolutely.
initial
Yeah,
concerns. And,
absolutely.
you know,
Yeah. And some of these, it may be that we feel that people aren't being paid enough money.
Well,
Right.
and to that extent, and
Yeah.
looking at some of the executive salaries last year,
Yeah.
looking at the market data, we saw some opportunities to close some gaps
Yeah.
for that very reason.
Yeah.
And we
Yeah,
did.
there could be, yeah.
And we are still, to those employees and other, a public agency. And so we have to be ensure of fiduciary responsibility as well as the personal responsibility to the employees. I don't think anyone's interested in eliminating or reducing them. But I think we are talking about growth and development in terms of what it is that we have resources to do.
Right. And I hope that we can all agree that the people that we're privileged to serve deserve the best.
They absolutely
The
deserve
best
the
that we
best.
can bring on board.
I think they deserve the best, and I think that we have incredible employees who we want to make sure have career paths and long and healthy careers with us.
So members, you all have more than indulged my concerns on this, and I appreciate you hearing me out. Thank you.
Thank you.
All right, thank you.
All right, agenda item 11, you want me to read it, or should we go on?
We've already called it up, but there is a motion that could be made, and I don't know if there's any presentation on the issue before the motion.
Do you want to present on agenda item 11? Or should we
Yes,
just go?
members, in this, again, I referenced the org chart earlier, and noting Perla Cavazos' new role coming in the governance and deputy administrator. As we took the chief of staff position and split some of those duties out into different directions in light of our enterprise changes, there's a statutory provision that allows an assistant administrator, technically I'm the administrator, but allows an assistant administrator if I'm not able to fulfill the administrator's duties. And this is, it allows the board to designate an assistant administrator. Now, one could read the statute and say, well, that's on an ad hoc basis, so if Mike gets run over by a bus, then yes, you can appoint an assistant administrator on that basis. If he comes back to work next week, yet again gets run over by a bus, you can appoint somebody else on the following week. But that's not a good practice. So what we've done is we have currently Susan Willers is the assistant administrator. So you always want to have a designated assistant administrator in there in the event that the CEO is unable to execute the duties of the office. So that's in essence what I'm asking. And I think you step back and think about the org chart that you looked at, and wanting to really consolidate a lot of the governance management functions and how we as a hospital district, as a governmental entity, perform and advance. It just makes logical sense to have that assistant administrator designation in place with the individual that holds that position. Now, I will say that whenever I'm going to be out for extended periods of time, that we have what's called a convening executive. And so we have a backup to the backup, if you will, so that if I'm going to be out for a week or so, we designate a series of people that we know are going to be in the office, so that way if there needs to be an emergency board meeting or whatever, the executive, there's somebody that can actually convene. So that way we have a backup to the backup.
So I'm glad you said that because I'm a little confused.
Yes.
I know right now, if you're needing to be out of the office for whatever reason,
Right.
not just a couple hours, but whatever, gone for a few days, then I've noticed that you will designate various executives, and it's not always the same one.
That's correct.
Right? And so I'm a little confused with what you just said
Yes.
about that versus this
Yes.
designation of deputy administrator.
And the reason that assistant administrator. So the reason that I
yeah.
brought this up is because I know that you all have received these emails where I say, hey, I'm going to be out of the office.
Right.
Here's the list of convening executives.
Right.
That is a different function when somebody's going to be literally maybe out of the office and unable to access email or text. This assistant administrator role is if you could have all the convening executives in the world, but there has to be somebody that actually has the authority to execute. So there's a difference between convening and actually executing.
So right now, who
certain authorities.
executes if you're gone?
If something bad were to happen, it would fall to Susan.
Okay, so this role, Susan's been in an acting case?
I don't know that it's acting.
Okay, I thought I saw acting on this one.
She was designated in 2016.
Okay, so she was designated in 2016 as the assistant administrator.
Correct.
And that duty now would no longer be Susan's, that duty would fall under Perla Cavazos.
Correct.
So that duty's already
Here's
been
what I
there.
found.
Sorry.
That's okay. Trying to help me out, thank you.
Or Siri.
So, yeah, let me. So what you're saying is that already existed, and it was
Yes.
Susan Willers, and that is moving to the position now that Perla
Ms.
Cavazos. Oh, okay, thank you for clarifying, I didn't realize that. And that is different than when you're gone and you say so-and-so will be answering your calls.
Because a convener is just somebody that just calls a meeting, and that's just to make sure that somebody's on deck that knows, hey, you got to call this meeting. But
Well, it didn't
convener.
seem like just calling meetings. It seems like when you were gone, there would be different executives, so you would say, this is the person in charge. That's the way I took it.
And I can certainly go back and clarify that,
Okay.
because there's a reason why we call it convening.
Okay,
executive.
well, okay.
Yeah, and I apologize for confusing it, I just
Yeah, I
thought,
just,
this is one responsibility, but I know that you all have seen the emails on the convening, and I,
okay.
unfortunately, I didn't mean to confuse the issue.
Okay,
but-
and this is a responsibility that
Yeah,
would now transfer from
Independent
one
of-
person to
yeah.
another? Okay.
yes.
Manager Jones?
Okay, so I just want to make sure, because it goes back to your org chart. What I heard you said, what this person is the next in line,
Next in line?
right?
Yeah, that's what I heard.
In terms of the organization, Ms. Cavazos would be next in line should, let's say you go out and get hit by a bus.
For purposes of executing the administrator's duties, yes. If I'm incapacitated, yes. Now, day to day, if you notice it's a very flat somewhat flat organizational chart, there's not, as there's currently is not, under the current organization, a number two person that you have to pass through. Because, so for example, if there's something that Jeff or Lisa needs me to sign off on, I need to make sure legal looks at it, need to make sure that if there is a sponsoring executive that they've looked at it, but ultimately I sign off on that. It doesn't have to be routed through a chain of command as much as it does just before it gets to me, in other words. There's not somebody that can stop it from
I
getting to
understand
me.
the structural flow,
Yeah.
so this person is not in that line of authority.
Correct.
But in your absence, this person then steps into that
If I'm
position.
incapacitated, yes. I need somebody that can step in quickly and keep
Well, if you
things
have
running.
such a person, I guess is what I'm saying, if you have such a person who can step in that situation, why do you need a convener?
Again, it's a backup to the backup. If I need somebody to convene the executive team, literally, that's why we call it convener. Just to convene, and I apologize for bringing this up, but I knew you all had seen these emails and I was anticipating
No, I was
some
confused
questions
already,
around
so
this,
thank
but,
you.
but nonetheless, here we are.
Well, why couldn't the assistant administrator serve that function, I guess?
Absolutely, she could, yes.
So why would you need to have a,
'Cause
why
I
would
like
you not do
redund-
away with that,
It
I
is,
guess is what
I
I'm saying.
like to see redundancy, and so, for example, if I send out, if I'm gonna be out for 2 weeks, let's say, and I'm not gonna have email or phone communication, I'm gonna look around, I'm gonna see who all are gonna be in the office, and say, okay, it could be that Ms. Cavazos is the convener for 3 or 4 days, and if she's gonna be out, then it could be that Monica's the convener. I need somebody to just call the meetings.
Yeah.
Now, in terms of execution authority, if I'm completely incapacitated, so let's say people can't reach me, or I'm in the hospital or whatever, then it falls to, regardless of who the convener is while I'm out, to the assistant administrator.
And today, that is Susan Willers.
Today, that is Susan
And
Williams.
that
Now,
would
we've
train-
never had to exercise that,
And I guess that's why I didn't even realize that was there, because we always got
Yes.
these convening emails. Okay, but
but
today, that's
as we're
Susan
making these
Willers.
other organizational changes and trying to consolidate a lot of the governance functions, and given that it's a statutory function, it just makes sense to move that assistant administrator designation to the person
From
that's now
Susan.
responsible for all the governance.
Okay.
I hear what you're saying, I still don't understand, I mean, it's yours to decide, but I just still don't understand why you would still keep a convening administrator, convening role, because the person, if I was an assistant administrator, I would have concerns with regards to, well, is it my responsibility or not?
Well, it is.
We don't have to spend time on it, I'm just voicing my point from an
It's just a
administrative point, I think that's
There's a decision that requires all the execs to come together. Somebody has to know, oh, you've got to call the meeting. And if the assistant administrator is going to be out or not on deck or whatever, you got to have somebody that can at least call the meeting and bring everybody together, and everybody
Could-
knows when this call goes
Can the
out.
assistant administrator then appoint such a person?
Good. Absolutely,
Which is my point.
absolutely. And when the assistant administrator is going to be out, she or he could say, all right, the 3 of you are now convening executives.
Right.
Absolutely.
All right, thank you. I was just confused on some aspects.
Any other questions? Julie?
I move that the board designate Ms. Perla Cavazos as the Assistant Administrator for Central Health pursuant to the Texas Health and Safety Code, Section 281.027.
Second.
A motion by Manager Oliver, seconded by Manager Greenberg. Any other questions? Seeing none, all in favor, say aye.
Aye.
All against? Any abstentions? Motion carries.
Thank you, members.
Okay, agenda item 12, discuss and take appropriate action on the 1115 Medicaid waiver delivery system reform incentive payment DSRIP projects, the Community Care Collaborative, including healthcare delivery arrangements and other community partnerships.
Okay, that's an action item.
What's that?
I'm gonna have to leave, sir.
Okay.
We're gonna lose our quorum. Do we need to vote on anything?
No votes.
For adjournment.
But we'd have to adjourn. We'd lose our quorum.
The rest of these items are informational items, we can bring them back again.
You wanna bring them back next?
I mean, how are you now, Jen?
Yeah, I was about to, is this next item for discussion, action? It says action item, so.
But we have to have a quorum to adjourn.
Yeah. If you leave, we can't discuss this,
Right,
so
right,
you
but I
have
was,
to
I was trying to
stay.
go to the next item, which says an action item. I guess I could stay for that for a few moments. Is there an action item on this? Item 12.
No, that's just our standard posting, we always include the
Oh,
word
oh,
action.
okay, okay.
13,
Neither one requires an action. So, you want to just adjourn?
so, what would, 12, we have every month, right?
It's always on
That's a
the
standing
agenda.
item. 13, if we do not discuss that now, what happens to 13?
We can put it on the next board agenda.
Excuse them?
It's the pleasure of the
Councils?
board on this one.
So we postpone those to?
Yeah, I would encourage
All right.
those.
All right, agenda items 12 and 13 will be postponed to the next Central Health Board of Manager meeting. Agenda item 14, confirm the next regular board meeting date, time, and agenda location. The next Central Health Board of Managers meeting will be held Wednesday, November 20th, 2019 at 5:30 at the Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. At this time, I'm ready to accept the motion to adjourn.
Second.
Okay, all in favor, say aye. Aye.
Thank you, members.